I don't mind. So welcome everyone to Maintaining Life section of the GEP Crash Course series. This is all of the stuff to do with like liver, kidney, gastro, all. And first of all, we're going to kick diabetes. I'm Jono. Some of the content was taken from a previous thing that I did with David, so I've credited him here. Great, so let's get cracking. Diabetes. The first question is, which of these features is more typical of type 2 rather than type 1 diabetes? Do one of you want to chip in?
Yeah, is it D?
It is D. BMI above 25 kilograms per meter square. Perfect. So this question was all about highlighting some of the differences between type 1 and type 2 diabetes. One difference is the pathophysiology. It's quite different. In type 1 diabetes, you don't have any insulin because the beta cells in your pancreas that normally produce insulin have been attacked by your own immune cells. It's an autoimmune condition, and you don't have insulin. Whereas type 2 diabetes, you do have some insulin, but the problem is not that you don't have any insulin, it's that your cells in your body are resistant to insulin and your beta cells are not working properly. Another different characteristics of the patient that presents with the different kinds of diabetes. So type 1 tends to be presenting in younger people, children, young adults, whereas type 2 diabetes tends to be people who are a bit older adults, and it's linked with certain lifestyle factors like obesity, kind of poor diet, plenty of junk food, and more sedentary lifestyle. And another key difference is the fact is kind of the speed of onset. So type 1 diabetes often presents as a kind of diabetic emergency called diabetic ketoacidosis, which is a very acute onset, and we'll talk more about that later. Whereas in type 2 diabetes, often those patients are completely asymptomatic, or the onset is just much slower with symptoms like polydipsia, polyuria, etc. Slow wound healing. So next question. Let's talk a bit about that insulin, which is so important to the pathophysiology of diabetes. Which of these processes does insulin stimulate? This one's a bit more tricky. Who's brave enough to jump in with this one?
I'm going to go with maybe B.
B, glycogenesis. And David's just arrived as well, which is perfect. You can jump in as well. Right. It is B, glycogenesis. Perfect. And that's because the other three processes on here are all processes to do with breaking down molecules to ultimately create glucose and create energy, whereas glycogenesis is all about storing glucose, and that's what insulin does. Insulin is all about getting glucose out of the blood. So when your blood sugar is high, your pancreatic beta cells release it, and insulin gets glucose out of the blood by causing it to go into your cells via these GLUT4 transporters, and by storing it in your cells, storing it in glycogen via glycogenesis, storing it in triglycerides, or storing it in fats via things like lipogenesis. And insulin also stimulates glycolysis, which is the breakdown of glucose to form acetyl-CoA to basically produce ATP, which you can use for energy. And insulin promotes glycolysis, basically in order to get rid of the glucose that's in your cells to increase the concentration gradient so that more glucose gets drawn up from the blood into your cells. So it's all about getting that glucose out of the blood into your cells. And insulin also inhibits glucagon, which does the opposite of insulin. We'll talk about that in a minute. And glucose 6-phosphatase, which is what allows glucose to ultimately be like your glycogen stores in the liver to ultimately put glucose into your blood. So it inhibits that, keeps the glucose in your stores and out of the blood. Okay, so glucagon, you can think of it like the antagonist of insulin. It does the opposite thing. So when your blood sugar is low, your alpha cells in your pancreas release glucagon, and glucagon, its whole mission is to get glucose into the blood. And it does this by breaking things down. It's a catabolic hormone. That's what catabolic means. So it stimulates those processes that break down the storage molecules. So it breaks down the fats via things like lipolysis. It breaks down the glycogen into, and it also promotes what's called gluconeogenesis, so forming glucose out of things, out of other substances as well. And in the long term, if you carries on being starved of glucose for a long time, glucagon will cause the breakdown of proteins. But your body only does that if it really has to, because it likes to keep a hold of proteins if it can. So insulin is all about building things and taking glucose out of the blood. Glucagon is all about breaking things down and putting glucose into the blood. And here is a truly excellent diagram that I've stolen from David, who made this himself. And basically, you can use it to help you to remember, well, it might be difficult to remember, but it's got all the main processes on it. And basically, the arrows that point away from glucose are going to be the ones that are stimulated by insulin, because insulin is all about removing the glucose. And the ones that point towards glucose are going to be the ones stimulated by glucagon, because it's all about kind of making more glucose, if that makes sense. So next question. What type of acid-base balance occurs in diabetic ketoacidosis, often referred to as DKA?
B.
B. Perfect. What an excellent crowd we have today. So it's metabolic acidosis, and yeah, that is what happens in diabetic ketoacidosis, and that is because, okay, so this is a kind of a complicated slide, but we'll just go through it step by step. This is the pathophysiology of what happens in a DKA. So it tends to happen to people in type 1 diabetes because they don't have insulin. So when you've got no insulin, you end up with lots of glucagon, because insulin normally inhibits glucagon. So when you don't have insulin, you get lots of glucagon. As we've discussed, glucagon causes loads of glucose to be produced, absolutely loads. So in a diabetic ketoacidosis, you get high blood glucose because there's loads being produced, and also the glucose that is produced and is put into your blood can't get into your cells because you need insulin to get your glucose into your cells. So you've got high blood glucose. Okay, that's one thing. Also, we have, as we talked about as well, glucagon promotes those breakdown processes, like promotes the breakdown of fats, which ultimately creates, as you can see in this diagram, via lipolysis and beta oxidation, it creates acetyl-CoA. Now, acetyl-CoA can only go in two directions. It can only go through the Krebs cycle to produce ATP, produce that energy, or it can go to produce ketones, which are another kind of fuel that the body can use. Basically, because you've got so much glucagon, glucagon promotes gluconeogenesis. Basically, what happens is one of the key components of the Krebs cycle is oxaloacetate. That basically all gets used up. The glucagon causes that all to get used up producing glucose. So the acetyl-CoA can't go through the Krebs cycle because the Krebs cycle has been broken. So it has to go to make ketones. So you end up with all the acetyl-CoA getting funneled into making ketones. So you end up with loads of ketones. Ketones they're also known as ketone acids, and that causes a metabolic acidosis. So recap: high blood glucose because of lots of glucagon and no insulin. Lots of glucagon produces lots of glucose. It also causes fats to be broken down to produce acetyl-CoA. Acetyl-CoA gets funneled into producing loads of ketones, which are acidic, because acetyl-CoA can't go to the Krebs cycle because oxaloacetate has been used up producing glucose because of glucagon. It's all a bit complicated, but it's on this slide, so it's there for people to read up again. We can always go over it again later if we need to. Let's crack on. Question 4, all about Jenny. She's a 19-year-old with type 1 diabetes. She's presented to the emergency department feeling unwell. She says she has vomiting and diarrhea. She's had that for 2 days and hasn't been taking her full insulin doses because she's been off her food. She's breathing very deeply. Her capillary glucose is 37. There are 4+ ketones on urinalysis, and her pH is 7.12 on ABG. Which of the following is the most appropriate initial management? What do we think? He's going to be brave enough to dive in.
I'm going to go with A.
Going to go with A?
Yeah.
It is A. Perfect. Because one of the main problems you need to address straight away is the dehydration. If someone's been vomiting, they've been doing loads of diarrhea all over the place, they're gonna be fluid depleted, and we need to get those fluids into them. Okay.
So you don't need insulin straight away. I'm just a bit confused if they don't have insulin.
You do crack on with the insulin pretty quickly, but the first thing to do is deal with the dehydration, because that's what's going to damage them kind of the most quickly. That's my understanding. David, what do you have to think?
Thank you.
Is there also something to do with glucose and the high glucose in the urine, and that drags out loads of water as well?
Yeah.
And you pee loads and loads and loads and loads.
Yeah. Yeah, that's also what causes the dehydration. Sorry, I missed that out. But that's, yeah, there are many things here that are causing dehydration. So yeah, I think the thing is, what we were taught anyway in our year was you need to deal with the dehydration first, but you definitely do give insulin pretty rapidly as well. We'll go over that in a sec. But for now, your consultant is impressed that you successfully treated Jenny with fluid resuscitation because of the fluid depletion. Before commencing IV insulin with dextrose, he tells you there's a biochemical marker that's incredibly important to monitor in DKA when administering this treatment. What's he talking about?
I'll go with C.
C,
Or
potassium.
A.
It's C, I mean, bicarb as well, definitely. But the potassium could be really dangerous because if it's too high or too low, it can cause arrhythmias. If you're giving someone insulin causes potassium to go into cells. That's just another thing that insulin does. So that can cause you to have low potassium in your blood, which can potentially cause arrhythmias that are very dangerous for your heart. Okay, so here's a little overview of DKA. Like we said, tends to happen in type 1 rather than type 2 diabetes because it happens when you've got no insulin. And in type 2 diabetes, you do have a bit of insulin, which inhibits the glucagon and prevents your body going into this full-out metabolic kind of spiral. Symptoms of DKA include weeing a lot and drinking a lot. Basically, as David was alluding to earlier, normally glucose is reabsorbed from your urine into your blood, in particular proximal tubules of your kidneys, but when you've got so much glucose, like you do when you're in DKA, it can't all be reabsorbed. So it goes into the urine. That creates an osmotic pressure, drawing water with it and leading to loads and loads of weeing happening, which causes you to be dehydrated. You also get nausea and vomiting, abdominal pain, this sweet smelling breath, which is interesting, and that's because ketones just have the sweet smell to them when you've got lots in your blood. And you get this Kussmaul breathing, which is basically your body trying to compensate for the metabolic acidosis. Your blood's very acidic. CO2 causes your blood to be acidic, so you do this deep breathing to try and get rid of CO2 to make your blood less acidic. As we talked about, investigations are going to show high glucose, high ketones, and low pH. And for your management, you need to give those IV fluids very quickly to deal with that dehydration. Then you need to give insulin, obviously because the lack of insulin is the whole initial problem here. And then you need to make sure you monitor glucose and potassium levels very carefully because insulin is going to reduce those. So we need to watch to make sure they don't get too low, and we can replace them if necessary. Okay, next question. Steve comes to his GP for a general checkup. Which of the following combos of results would allow us to diagnose him with diabetes? This one might take us a couple more minutes to read.
C.
C, excellent, very well done. And that is because, so to diagnose type 1 or type 2 diabetes, we've got a few different tests we can use. Basically, they all involve testing how sugary your blood is, how much glucose there is. And one of them is a fasting glucose. So basically, you make them not eat anything for a while, and then you test their blood glucose, and then their blood glucose, because they haven't eaten anything to put sugar into their blood for a while, should be quite low. It shouldn't be higher than 7. Or you can do a random glucose, and the blood glucose shouldn't be higher than 11.1, because it just generally shouldn't get higher than that. Or you can do an oral glucose tolerance test, where you give them sugar, a couple of hours later, you measure their blood glucose, and it shouldn't go higher again than 11.1. Because your insulin in your blood should be able to keep a handle on that and keep it lower. With type 2 diabetes, you can do this thing called HbA1c, where you're measuring basically how much sugar is attached to your red blood cells. And so that's a good measure of how sugary the blood has been over the last 3 months, because that's the lifespan of a red blood cell. And that shouldn't be higher than 48. So, like with anything in medicine, we're using a variety of things to sort of come together into our clinical judgment to make a diagnosis. So if they've got symptoms of diabetes that are pointing you towards a diagnosis of diabetes, like polyuria, polydipsia, lethargy, if we've just got one test result, one of these test results that's indicative of diabetes, that is enough to diagnose it. Whereas if they have no symptoms of diabetes, they're asymptomatic, you need 2 separate tests, like you need a fasting glucose and an oral glucose tolerance test, or a couple of the same test over time to confirm that diagnosis of diabetes, because you haven't got the symptoms to increase the clinical likelihood by them. Yeah, if that makes sense. So next question. Let's say Steve's been diagnosed with type 2 diabetes. How often should we be checking his HbA1c? Classic diabetes monitoring question. Very GP. What are we reckoning?
I'm kind of between B and D.
That's very good. So apparently it's D. This is kind of just a memorizing question. 3 to 6 monthly. I tried to remember it like, well, HbA1c tells you about what the state of the sugar in the blood for the last 3 months, because that's the kind of lifespan of a red blood cell. So 3 monthly or 3 to 6 monthly. Is how often you should check HbA1c. Probably it's going to be checked 6 monthly. In fact, now because of COVID, they're checking things like diabetes less and less frequently, aren't they? So, but it ideally should be checked 3 to 6 monthly. So in terms of monitoring of diabetes, we've spoken about HbA1c. You can also measure your capillary blood glucose. People with type 1 diabetes in particular will need to measure that regularly so that they can adjust their insulin doses accordingly throughout the day, because they need to self-administer insulin. Talk about that a bit later. Or you can also get this thing that people with type 1 diabetes have called Freestyle Libre, which is actually pretty cool. So it measures the glucose levels in your interstitial fluid using a skin sensor, and it means you've got constant monitoring of your blood glucose levels. And also, crucially, another very important thing that GPs have to do, monitor and manage the complications of diabetes. We'll talk about complications of diabetes later, but basically you need to do things like give them regular screening of their eyes, and regular checks to make sure their peripheral nervous system is working properly. Basically, you've got to monitor those complications that can happen because of high blood sugar over a long time. We'll talk more about that later. So, as well as lifestyle measures, what is the first line drug we should put Steve on to try to control his diabetes? Steve is really the star of the show tonight.
I think B.
B, excellent. Metformin. That's the classic first line diabetes drug that we just whack people on, and it works pretty well usually. But if it doesn't work well, what do we do? Steve's HbA1c has hit 60 despite lifestyle measures and metformin therapy. He's really been trying his best, poor guy. What's the most appropriate next step? What do we do when metformin just doesn't cut the mustard?
Maybe D.
Ooh. I was going to say
Excellent.
B.
You're going to say B. That is also a decent idea. But what we've been taught just in the basic pathway is that you just continue the metformin and add a DPP-4 inhibitor. In practice, maybe they do double metformin dose. I don't know. But what we've been taught, my understanding is you continue the metformin and then you add a DPP-4 inhibitor, or one of the other diabetes drugs, which we'll go over in a minute. Basically, you continue the metformin, add another diabetes drug, because you need to increase that kind of increase your medications you're giving. All right, next question. Patty's new prescription of metformin does not bring down HbA1c despite good concordance. A doctor decides to put her on gliclazide, a sulfonylurea. What is the cellular mechanism of action? Sulfonylureas. In case you hadn't noticed, we're now doing questions just on general management of diabetes, particularly type 2. And then we're going to have a couple of slides on that.
I have no idea. I'm just going to give a wild guess. D.
D. Okay, so not for this one. So this is just yeah, the kind of thing that you learn in med school and it's very easy to forget afterwards. But I think for GEP year 1, they like you to know the mechanism of action of diabetes drugs. Basically, it blocks ATP-dependent potassium channels, causing your beta cells to release more insulin. So actually, sulfonylureas are one of the diabetes drugs that has a risk of causing hypoglycemia if you give too much of it. So we need to watch out for that. Talk about that in a moment. Okay, so this is just a big slide of all the main diabetes drugs. I won't go through it in loads of detail now, but hopefully it'll be useful. Metformin, like we said, is the first-line drug. The main thing it does is decreases hepatic glucose output. So your livers have huge stores of glucose in the form of glycogen, and I think other things as well. So metformin helps to stop your liver releasing glucose, as well as doing other things as well that are useful. That's the main thing it does. And key side effects of metformin include GI disturbance and lactic acidosis. They also, I think, in GEP year 1 like you to know some side effects. DPP-4 inhibitors, basically, so there are these things called incretins, which is a hormone that increases your insulin secretion. So you get GLP-1 mimetics. A GLP-1 is an incretin. So if you give people GLP-1 mimetics, you increase their insulin secretion because you're giving them a hormone that increases insulin secretion. DPP-4 is an enzyme that breaks down incretins, so reduces insulin secretion. So if you give DPP-4 inhibitors, you're going to decrease the amount of DPP-4, you're going to decrease the breakdown of incretins, and you're going to increase insulin secretion. So we can also give DPP-4 inhibitors. You get other things like pioglitazone, which increases your insulin sensitivity in your peripheries. So it helps insulin to work better. You get sulfonylureas, like we've spoken about, that stimulates the release of insulin. But because it's releasing insulin, it can cause weight gain, hyperglycemia. And you also get these things, which I think are a newer drug called Sglt2 inhibitors. They're pretty cool. Basically, like we've spoken about before when we were talking about DKA, the proximal tubules of your kidney reabsorb glucose from the urine into the blood. If we block this, basically because SGLT2 is the protein that allows the reabsorption of glucose from urine into blood. If we block SGLT2, that's going to increase the amount of glucose being excreted in your urine, thus reducing your blood glucose. And but the problem with that is you get very sugary urine, so you can get increased urinary tract infections. Okay, and then here is the kind of algorithm that we've been taught for the drug management of type 2 diabetes. Basically, if they've got their HbA1c that's a bit high, you put them on metformin and you try to get their HbA1c. Okay, so first of all, we try to get their HbA1c to 48. If you put them on metformin and their HbA1c rises to 58, we add another drug. Basically, if their HbA1c rises to 58, add a second drug. And on this second line drug, we're trying to keep the HbA1c at 53 rather than 48. I think that's partly because of the risk of hypoglycemia. So we actually don't want their blood sugars to be too low. So we're raising the target. And basically the second line therapy is we have metformin and add another diabetes drug. This can be one of the ones that we've just spoken about, DPP-4 inhibitor or pioglitazone or sulfonylurea, and that's up to clinical judgment. If the HbA1c rises to 58 again, we basically just add another drug in. We have triple therapy. We keep the metformin and just have 2 other diabetes drugs. So first of all, try and get their HbA1c at 48, add metformin, try to keep it at 48. If it goes all the way up to 58, add another one in. If it goes up to 58 again, add another drug in. Okay. Or what you can do if your 3 drugs just aren't working, or if you want to not do 3 drugs and you want to just do 1 drug, you can stack them on insulin. That's another alternative when you're getting that far down the line of management. But for GEP year 1, don't worry too much about that. Just remember metformin if HbA goes 48 or above, and then if it goes up to 58, add another diabetes drug, and then the target is 53 rather than 48. Okay, I think this may be the final question, or at least second to last question. Aisha's dizzy at school and starts shaking. She tells you you know she has type 1 diabetes. Appropriate treatment for the most likely medical problem.
I think I'd give her some Lucozade and some toast.
Perfect. Basically, she's having a bit of a hypoglycemic episode. She maybe has had a bit too much insulin, reducing her blood sugar a bit too much. So what you need to do then is basically, if they're well enough to eat something, just give them some fast-acting sugars like Lucozade or like that, and then also a slow-acting carbohydrate as well. Okay, so this is type 1 diabetes management. Basically, to manage someone with type 1 diabetes, they need to use insulin because they haven't got any insulin. So we just replace it with kind of artificial insulin. And usually we give a combination of a long-acting insulin that they take, that just acts in the background all day, and then a short-acting insulin 30 minutes before a carb intake at meal times to just kind of boost that insulin for the point of time when they need it, when they're about to have a big load of carbohydrates. You need to monitor those carbs, monitor the blood sugar when you wake up, at each meal and before bed, because those are the key times when you need to know your blood, because it can influence the amount of insulin that you take. And then you also need to monitor for those complications to do with prolonged high blood glucose, which we'll talk about last slide. And then you need to watch out for hypoglycemia, which is a key complication of injecting insulin, because insulin is all about, like we said, getting glucose out of you. That can go too far. You can end up hypoglycemic. You can end up with symptoms of that, like shaking, weakness, etc. And then that needs to be treated with a rapid-acting glucose and a slow-acting carbohydrate, like we said. Or if it's really severe, then they might need some IV dextrose and IM glucagon, because like we said, glucagon is all about getting glucose back into the blood. So we can use that if they really need glucose in their blood. This, I think, is the final question for diabetes. So Granny Smith has had type 2 many years now, and it's not always been very well controlled. Which of the following is a microvascular complication of diabetes that she might suffer from? A, perfect. Diabetic nephropathy. Here are the complications that you get when you've got chronic high blood sugar. They tend to be conventionally split into two main categories: macrovascular and microvascular. The macrovascular complications are stroke, heart disease, coronary artery disease, and peripheral ischemia. And coronary artery disease is a really important cause of death in people with diabetes. And peripheral ischemia can lead to poor healing, particularly around your feet. It can lead to ulcers, which then don't heal very well and can be very sore and nasty. Then you get the microvascular complications, which are caused by problems in the tiny little blood vessels. And that causes problems in the tiny little blood vessels of your eyes, causing diabetic retinopathy. So that's why they need regular eye checks, people with diabetes. And it causes chronic hypoglycemia. It causes problems in the tiny little micro blood vessels in your kidneys. Particularly commonly, it causes glomerulosclerosis. And it can also cause problems in your nerves, in your peripheral nerves, causing you to have a kind of a peripheral neuropathy where, say, your fingers or your toes go numb, and that can lead to a problem because you can end up then kind of like using your feet in ways that normally you would register as painful, but you can't feel them, so you don't. So you end up with quite strange mangled joints. Bucco joint is what it can be called. So we need to monitor people with diabetes for these complications so we can address them early and try to prevent them. And then that's diabetes for you. So special thanks to David, particularly for some of the really good content there. And then also here are just some other great resources. Always love 0 to finals. Okay, so that's me done. Thank you everyone for listening and participating.
Thank you very much. That was super helpful.
So in case you don't know me, hi everyone, my name is Dom. I'm currently in my final year at George's, and before I begin, you should know that my first degree was not in science or anything related to medicine. I didn't even do science A-levels. So I must apologise if some of my explanations are not particularly sciencey, but I thought it was also important to let you know that it means I completely understand how daunting all of this stuff is. And yeah, you will get there in the end. If you have any questions for me, you can email me afterwards. I put my email on the last slide. And if any other questions come throughout, maybe put them in the chat and I'll see if I can answer them. Just one question to begin with for everyone. Does anyone know what the O of my gourd introductory slide represents? That is a OGD of a Barrett's esophagus, so we'll come on to that a little bit later. So right, aims of the session, we'll recap a little bit of GI tract anatomy and physiology, then we'll discuss gourd in a little bit of detail, and then move on to its management and complications before touching very briefly on peptic ulcers. So, as I'm sure you know, the GI tract is a continuous tube that runs internally from the mouth to the anus, and it's about 8 to 9 meters in length. The tube is divided into sections that serve different functions according to their macro and micro structure. For example, different cells do different things. Now, I don't really want to get into this in any detail, but the embryology of the GI tract is quite tricky. But very, very basically, during early development, you have a single tube representing the GI tract, which then rotates and convolutes in a number of ways, and outpouchings form that go on to become the various sections of the GI tract that we recognize today, and the accessory organs. It's divided with the help of sphincter muscles, which are muscles that constrict. Just as an interesting side fact, the body has over 70 sphincter muscles in it. Things like the pupil, which contracts to let different amounts of light in. But yeah, these sphincter junctions prevent, or are supposed to prevent, backflow or regurgitation of the contents. So starting at the top, you have the mouth, which is, and behind that you have the pharynx, which is the Greek word for throat, and can be divided into the nasopharynx, which is behind the nose, the oropharynx, which is behind the mouth, and the laryngopharynx, which is around the level of the larynx. Just inferior to this, traveling down the GI tract, you have the upper esophageal sphincter, and then you have the esophagus, also called the gullet, which is a 25 centimeter long sort of muscular tube which propels the chewed up food from the mouth to the stomach via a series of contractions that we call peristalsis, which I like to think of as a self-propelling frube yogurt or toothpaste tube, but I prefer, I like frube more. Then continuing down, we have the stomach, which is a distensible, so it's sort of expanding sac, shrouded in layers of muscle fibers which run in different directions, and therefore the different muscular layers allow the stomach to expand and contract in a different way that give rise to a churning motion which further breaks up the food. So in adults, the stomach's about 25 centimeters long and contains between 2 and 4 liters. And just by contrast, the stomach of a newborn baby retains around only 30 milliliters. Then, if you imagine a piece of food, after the stomach, you pass through the pyloric sphincter, which is another muscular sphincter that separates the stomach from the first part of the small bowel called the duodenum, which is around 12 centimeters long. And in fact, duodenum gets its name from the Greek word for dodecadactyly, I think, meaning 12 fingers long. So yeah. Then you have the jejunum, which is the second part and slightly longer part of the small intestine, which is around 8 foot long. And after that, we have the ileum, which is 12 feet long. And it's important not to get the spelling wrong, because ileum is the gut, or part of the gut, whereas the ium, the ileum, is a bone within the pelvis that gives name to the iliac arteries and the iliacus and iliac muscles and so on, which are attached to the pelvis and help with standing up. Then we have the large bowel, which is a much wider diameter tube divided into a number of sections: the ascending colon, transverse colon, descending colon, which basically go up your right side, across your abdomen from right to left, and then down into your left lower quadrant before reaching the sigmoid colon, which sigma means S-shaped. And after the sigmoid colon, you have the rectum and the anus. The accessory organs I mentioned earlier are things like the liver, the pancreas, the gallbladder, and the gallbladder produces bile, which helps emulsify fats. And we've just heard a lot about how the liver and pancreas work in synergy. So a little bit more, you can see on this lovely image on the left from Netta, the little wrinkles in the stomach, which are called rugae, and the stomach is of a slightly darker color than the esophagus. So if you look in the right-hand image, you can see a smoother appearance to the esophagus, and then this wrinkly, rugated appearance to the stomach. And the esophagus is lined with a type of epithelium called, it's got a quite grand name, non-keratinized stratified squamous epithelium. And then the stomach contains simple columnar epithelium. Basically, squamous epithelium serves to protect the body from pathogens and also prevent fluid loss, and is found in the mouth, the esophagus, and places like the vagina. The simple columnar epithelium is found in the stomach and the intestines and secretes mucus, which protects itself, enzymes, and acid, which allows nutrients to be absorbed into the bloodstream. Now, if I can draw your attention to the junction or the border between the smooth esophagus and the wrinkly stomach, where it goes from pink to sort of a rich flamingo pink, there's a zigzag line, which is referred to as the Z line, which demarcates the lower esophageal sphincter. This sphincter is very relevant to GORD, and we'll touch on that a little bit more later. But essentially, the inner lining of the stomach has several mechanisms to resist the effect of the sort of acidic environment of the stomach on itself. But the mucosa of the esophagus does not. And this esophageal junction acts as a one-way valve mechanism to prevent that gastric juice flowing back up into the esophagus. And so after you eat something, the esophagus peristalses, squeezing food down into the stomach, and the lower esophageal sphincter relaxes, and then it contracts to prevent chyme, which is a mixture of food and stomach acid and digestive enzymes, from going up back into the esophagus. Right. So this image, the one on the right, describes the mechanisms of digestion, which we've alluded to before. You have propulsion, which is literally propelling the food bolus forward. Bolus just means ball. You have chemical digestion, which refers to the sort of emulsification and enzymatic activity, which allow for, moving on to absorption, where nutrients and water are able to get into the bloodstream for further processing by the other accessory organs and things like your kidneys. And at the very start of this all, you have mechanical digestion. However, there's also another phase of digestion, which is another way of looking at it. So another phase, and there on the left-hand side of the screen, first you have the Caphalic Phase. Caphalic means something relating to the head. And essentially the Caphalic Phase of digestion occurs before you've even eaten any food. And often a Nobel Prize was awarded for it, for the discovery of it in 1905, I think, by Ivan Pavlov, who rang the bell and when the dogs made the dog salivate. But he won his Nobel Prize for doing experiments, very clever experiments, where he established that just by showing food to animals, their stomachs became more acidic. So without even feeding them, there was this Caphalic Phase, which sends impulses down by a nerve called the vagus nerve, which essentially stimulate various chemicals to be produced in what's called the gastric phase. And the gastric phase then gives rise to the intestinal phase of digestion. It's all pretty straightforward so far. Now, this slide I think is quite simple, but the concept is quite complex, I think. Essentially, you have an acidic environment in the stomach, and the way of achieving that acidic environment in the stomach is by producing acid, so gastric acid, and this acid helps to sterilize food, and it also converts a chemical called pepsinogen to pepsin, which is able to break down proteins. Now, when inside the stomach, you have these gastric pits, which are little spaces or little kind of fissures that are lined with a variety of cells, each of which serves a different function. And the three main cells to remember for your revision are G cells, chief cells, and parietal cells. When the stomach is stretched, G cells are triggered by these stretch receptors in the stomach, so when the muscle physically stretches, to produce gastrin. And gastrin stimulates parietal cells to produce hydrochloric acid. Parietal cells also are stimulated by histamine. And next we have chief cells, which secrete pepsinogen, which then mixes with hydrochloric acid to form pepsin. Proteins, as I mentioned earlier, are broken down by pepsin, which the word comes from the Greek word pepsis, meaning digestion, and from which we get words like dyspepsia, meaning bad digestion, and Pepsi, the drink, which was originally thought to cure dyspepsia. Pepsinogen release is stimulated by the vagus nerve, which we also mentioned earlier, and by gastrin secretion. The little chemical equation is part of what's called the bicarbonate buffer system, and this occurs throughout the body, but predominantly in the gut, in response to cellular respiration, and essentially helps the body to self-regulate its pH. Basically, hydrogen ions are produced from a reaction between water and CO2, which is then catalyzed by an enzyme called carbonic anhydrase to form carbonic acid, which is then split into bicarbonate, which is alkaline, and H+ ions, which is basically acid. It's a self-regulating equation, which means if the environment becomes too acidic, it will push back the other way and alkalinify itself. So yeah, as we just said, if you imagine the stomach has to be acidic environment, and this is achieved through a number of mechanisms. The most important ones for you in terms of GORD to remember are the proton pump, which is a hydrogen potassium ATPase pump, which exists in these parietal cells and pump out from the parietal cell into the lumen of the stomach hydrogen ions, acidifying the environment. You also have bicarbonate and chloride exchanger pumps occurring in the blood and force chloride ions, negatively charged ions, into the parietal cell, and then from the parietal cell to bind with the hydrogen ions to form hydrochloric acid. Now, there's a condition where, because you've it's not a medical condition, but a state of an alkaline pH of the blood that occurs typically after eating a meal, is referred to as alkaline tide. It's totally normal, but essentially because you're pushing, if you look at the diagram, because you're pushing the hydrogen ions to the right, so to the lumen of the gastric pit and into the bag of the stomach, on the left-hand side, you're pushing these alkaline ions as well. And it normally lasts a couple of hours, and it's self-limiting. Now this slide, goodness me, it looks absolutely crazy. So I think we should avoid it. GORD is a very straightforward condition. It refers to symptoms of esophagitis secondary to gastric contents that's refluxed up into the esophagus, typically presenting with episodic epigastric retrosternal pain and discomfort. What does that mean? It means it's not there all of the time. Epigastric means it occurs just below your ribs, just below your xiphy sternum, so in the middle of your, about between your, well, it occurs just above your umbilicus in that what they call epigastric region, and sometimes it can feel in the back of the chest, so retrosternal pain, discomfort. Some people also call this heartburn, acid reflux. It's a very, very common condition that's thought to occur in between 12 to 41% of the population. As you can see in the diagram on the right, you have this lower esophageal sphincter, and when it's not functioning properly, or when there's significant amounts of pressure in the stomach, acid and gastric contents can travel up through the esophageal sphincter and irritate the lining of the esophagus. Risk factors for this include obesity, a condition which is called a hiatus hernia, which is essentially where part of the stomach ends up processing through the diaphragm and becoming almost part of the the lower esophageal sphincter tone is lost, and the muscle doesn't work that effectively, and it's quite commonly associated with acid reflux. As you get older, your muscles get a bit weaker, and so your lower esophageal sphincter doesn't work the way it once did. So you often see, if you're on a geriatric ward, everyone's taking lansoprazole or omeprazole, which are types of proton pump inhibitors. If you smoke, smoking relaxes the lower esophageal sphincter. Alcohol is a direct irritant to the stomach. Coffee relaxes and acidifies the stomach environment. Spicy food irritates the stomach. Stress causes all manner of problems. But in times of stress, the stomach actually becomes slightly more acidic. H. pylori infection. H. pylori is a bacterium that lives in the stomach. The reason I've written Barry Mitchell is because he was the guy, or he was one of the two chaps who, first of all, isolated it as a possible cause for the development of peptic ulcers. So we'll come on to him a little bit more later, but basically he drank a solution containing this bacteria and developed a peptic ulcer to prove a point, and he also got a Nobel Prize. Finally, pregnancy, due to the increased abdominal pressure, that also predisposes you to getting GORD. So when you see someone who's complaining of a sort of retrosternal pain or a pain in their upper abdomen in the center, ask about the risk factors that I mentioned on the previous slide. The symptoms that they will likely report are heartburn, dyspepsia, which is quite a sort of nebulous term, but it refers to things like coughing at night time or when you're lying down, feeling a bit refluxy. As we said before, heartburn. It's quite non-specific. Very few patients will present with vomiting, but some might feel a bit nauseous or not feel like they want to eat. But typically this occurs after eating, so they get indigestion. And there's a condition which is called water brash. I must confess I haven't heard of this in isolation before starting, but it's basically producing too much saliva to try and neutralize that acidic environment that's causing you problems. Symptoms may well be exacerbated by lying down, but it's important to note that pericarditis, which is a inflammation of the sac that surrounds the heart, also presents with a pain behind the sternum, which is alleviated by leaning forward. So it's important to ask questions about related and associated symptoms, such as variation according to when you eat, if it's worse after eating. In terms of examination, you want to do a chest exam, which includes the cardio and respiratory systems, because a lot of these people might get coughing and spluttering, and you want to fully evaluate those systems. You want to do an abdominal exam, and both of these exams aren't particularly specific, and you won't have any major findings, but it might be useful to detect other conditions such as pericarditis or gastritis. If someone's got a pain when you press on their stomach, they might have gastritis. So it's more to rule out other things, because you won't rule in. GORD doesn't present really on clinical findings. The complications of GORD, on the right here, you see you get a transient loss of lower esophageal sphincter tone, which is allowing the acid to affect the esophagus. The stomach acid then causes inflammation of the esophagus, which is referred to as Barrett's esophagus, which, if we go back to the first slide, I won't, but if you go back to the first slide, you can see there's this pinky color in the esophagus, which is the infiltration of the irritation of the normal, nice, smooth squamous epithelium that's in the esophagus. Now, prolonged damage can cause disordered cell changes, which are referred to as dysplasia, and a small number of patients who have this dysplasia, a very small number, I think 2% of patients with prolonged dysplasia, so confirmed Barrett's esophagus, and will go on to get an adenocarcinoma or adenocarcinoma, which is a carcinoma of glandular tissue, which has quite a poor prognosis, but it does, just because you have Barrett's esophagus, it does not mean that you will progress on to having cancer. It's often held at that stage and subject to review with camera tests and so on that are done every year or so. So in terms of management of GORD, because it's a clinical diagnosis, we will discuss later on some of the investigations that you might do, but essentially it's a clinical diagnosis of someone presenting with acid reflux and no other cause or any risk factors that might alarm you. So things like losing weight, raising the head of your bed, so when you go lie down flat, you're not going to reflux acid into your esophagus and cause that irritation. Obviously stopping smoking and reducing alcohol intake, and removing any of those very easily modifiable factors such as hot drinks and spicy food. Eating more than 3 hours before bed is also very useful. And there are certain drugs that irritate the lining of the stomach, such as non-steroidal anti-inflammatory drugs, particularly nitrates, which relax the lower esophageal sphincter, some calcium channel blockers, and also tricyclic antidepressants. I don't expect you to know all of these yet, but it's useful that if someone says they're taking, oh, sorry, let me get that. If someone says that they're taking NSAIDs or they're on nitrates, so a GTN spray, that might increase their risk of developing acid reflux. Now, the management is quite straightforward after this, where you give over-the-counter antacids, such as Gaviscon. That's your first line of treatment. And if that doesn't appear to work, then you give a drug called a PPI. And a PPI is a proton pump inhibitor, which stops that parietal cell from pumping that H+, the hydrogen ions, into the stomach. And drugs typically end in azole, such as omeprazole or lansoprazole. If there's no response, then you double the dose. And if you still have no response, you add a drug which is called a histamine receptor antagonist. So an antihistamine drug that some of which are used in the treatment of allergic reactions. As we mentioned before, histamine is implicated in the stimulation of parietal cells to produce H+ ions and gastric acid, basically. So if you put a antihistamine drug on there, it reduces the overall production of acid. If this is a very, very persistent problem and a patient's reporting significant problems from it and that there aren't any reasons not to proceed, a surgical option is sometimes used. And so if they have a condition like a hiatus hernia, for example, this is also the treatment for that. The image shows the Nissen fundoplication, and the fundoplication essentially is a surgery which is performed through a keyhole incision, or a series of keyhole incisions, where the fundus of the stomach, which is the bit that's being grabbed by that little grabber there, and is wrapped around the lower esophagus and forms a little cuff. But in order to receive one of these surgeries, you'd have to have severe symptoms, and it would be refractory, so it would persist in spite of medical therapy, and you'd have to have confirmed reflux. So sometimes they insert an electrical wire that monitors the pH of the stomach that you wear for 24 hours. It's quite unobtrusive, actually, but it's a prerequisite for having the surgery. Now, the drugs I mentioned earlier, here are a list of proton pump inhibitors. OD does not mean overdose, it means once a day, and BD means twice a day. You will see these very, very commonly prescribed. However, the most common two that you will see are lansoprazole and omeprazole. Different trusts recommend different things, but generally speaking, you will see one of these two drugs given, partly because they can be doubled in quite an easy way, and they're quite cheap to produce. Here are the histamine receptor antagonists, so ranitidine, famotidine, and nizatidine. Most commonly, ranitidine is most commonly prescribed histamine receptor antagonist. Now, I mentioned earlier about a camera test. There are some times where you might suspect cancer, and the red flags for cancer are individuals who present with dysphagia, which is difficulty swallowing, or they've got the sort of reflux and dyspepsia symptoms plus weight loss, and they're over 55. This is because they may well have either a gastric cancer or a esophageal cancer, and it's important to examine them to see if there's any abdominal mass, because an abdominal mass would also merit referral for a 2-week wait endoscopy. So yeah, it's important, and NICE says do not routinely offer endoscopy to diagnose Barrett's esophagus, but consider it if the person has GORD. But it's obviously subject to a case-by-case basis. If there's a strong family history of esophageal cancer or the patient's incredibly worried, then consider a referral, but know that it may not meet the requirement for an endoscopy, and the gastroenterologist in the hospital may well say, well, the waiting list is 6 months, so make sure you try all of the drugs first, because they do tend to help people feel a little bit better. Now, peptic ulcer disease, I'll just be very brief on these. they are quite common in the particularly in the elderly population, and they are thought to be due to a release of a reduction of the gastric mucosal resistance. The two most common mechanisms that you'll hear about are NSAIDs, so non-steroidal anti-inflammatories, and aspirin, which stop and inhibit cyclooxygenase 1, which is an inflammatory chemical in the body, which helps as an anti-inflammatory, so it helps with pain. However, COX-1 also helps protect the mucus in the upper GI tract. The other cause of, one of the other common causes of peptic ulcer disease is H. pylori, which we mentioned earlier. So H. pylori is a gram-negative anaerobic bacteria. It's able to force its way into the gastric mucosa, and the breaks that it creates in the gastric mucosa expose the epithelial cells underneath to acid. It also produces ammonia, which tries to neutralize the acid. So and the ammonia itself directly damages the epithelial cells. There's a slight paradox in that the H. pylori, which is commonly implicated in the development of gastric cancer and peptic ulcer disease, is also the most protective for esophageal cancer, and that's because of the neutralization of the acid in the stomach. It's just one of those things that it's just a feature of the bacterium itself. So the presentation, often it's a similar presentation to GORD. You might hear someone who's been taking loads of NSAIDs, so for a few months or a couple of years actually. They might have osteoarthritis and they've got this pain in their abdomen. And the two types of peptic ulcer that you will encounter are duodenal ulcers, where the pain tends to be improved by eating because the acidic environment which is causing the pain is occurs in the stomach basically, and the duodenum is given a little bit of relief while the stomach processes all the food. And then there are gastric ulcers, which is where the acidic environment of the stomach is exacerbated by eating as the pH drops. So in terms of investigations, patients under 55 undergo non-invasive H. pylori testing, which is basically using a mechanism called the urea breath test, where they basically measure the amount of urea, which is a byproduct of ammonium, breakdown in your breath. There are also stool antigen tests, but the most sensitive is certainly H. pylori testing. One thing that's important to remember with this is if you have a patient who's been receiving treatment for GORD, so has been on a PPI, you have to stop the PPI at least 2 weeks beforehand to allow that acid to build up, because the H. pylori will be more detectable in those that acidic environment where it's sort of feeding off it and trying to neutralize it itself. When you, if you're over 55, they should have an OGD, which is an esophagogastroduodenoscopy, which is a camera that passes down through the throat into the stomach and the duodenum, and biopsies are taken of the peptic ulcer to decide whether or not, or determine whether or not it's benign or malignant. If you have confirmed H. pylori, they treat it for 7 days with a triple therapy of omeprazole, so a PPI, metronidazole or amoxicillin. So metronidazole given if they're allergic to penicillins like amoxicillin, and then clarithromycin twice daily for 7 days. Sometimes you get peptic ulcer disease without H. pylori infection. Essentially, the treatment is stop the NSAID or the aspirin, which might be causing it, giving drugs that neutralize the stomach acid or relatively neutralize it, such as PPIs, is also very helpful. And then sometimes a follow-up biopsy to show healing and exclude malignancy. Very rarely do they perform surgery, and usually it's only used for complications of peptic ulcer disease, such as peptic ulcer rupture or perforation. Right, sorry that was a bit long. If you have any questions, please do feel free to email me and I'll get back to you. I can also send some notes out that I have on this. Yeah, so thank you very much.
Thanks, Dom.
Thank you, Dom. Okay, so my name is Ollie, formerly known as Olivia, and we are going to do some lovely revision of the liver. This is a revision session. I'm not going to teach you everything about the liver because that would probably take about 3 days. So what we're going to do today is touch on the anatomy and the physiology and the multiple functions of the liver, and then look at things like LFTs, jaundice, and sort of some poisoning with common things such as paracetamol and alcohol. So just starting off with some anatomy. So the liver is a lovely, huge organ that most people think is in your right upper quadrant, and it is in your right upper quadrant, but it also is so big that it actually spans pretty much all of your kind of epigastric and both right and left hypochondriac regions. It's intraperitoneal, so it's within the peritoneal cavity. Once you guys get a bit further along in your training and you go for sort of looking at laparoscopic surgery, you can always orientate yourself by seeing where the liver is, because that's exactly what it looks like on the camera. It's also contained within a nice capsule, which is important when we come on to the LFTs later. So in terms of gross anatomy, it's mostly made up of two major lobes, which are your right and your left, if we're looking sort of anteriorly, and then you've also got the posterior sort of caudate lobe that you can see when you're looking kind of from behind. And then once you break down the lobes, you've got 8 segments. You don't need to worry too much about all the segments. Just be aware that it does have lots of different segments. There's also quite a few ligaments, as we can see on the screen here. But the most important one to note is the falciform ligament. So this is the one here that separates the right and the left lobes. And then the coronary ligament is at the top here. So on the posterior aspect of the liver, which is kind of shown by this black and white diagram up here, we've got a groove for the inferior vena cava. We've got lots of indentations here for different parts, different organs within the abdomen. So you've got an esophageal indentation, got a gastric indentation, suprarenal indentation. So just be aware that even though on the front it looks nice and smooth and kind of uniform, on the back it's much more kind of lumpy. So talking about the blood supply now. So the liver is one of the organs in the body that has a dual blood supply. So in terms of its arterial supply, it's got oxygenated blood coming from the hepatic artery, which comes from the celiac trunk, which if you think about your 3 major arteries that come off your abdominal aorta, your celiac trunk is your first one, and that comes off at about T12, and it gives rise to your common hepatic arteries, which then give rise to both your gastroduodenal, your right gastric, and your hepatic arteries. And then from your hepatic artery, you get your left and your right hepatic branches. And from your right hepatic branch, it also gives off the cystic artery, which is important as it supplies your gallbladder there. And in terms of drainage, you've got your hepatic vein. So that is going to come from both your right, your middle, and your left parts of your liver, and it's going to drain into the inferior vena cava. Now, I mentioned that the liver has a dual blood supply, and that's because the second part of the blood supply comes from your portal vein. So this is deoxygenated blood, and it's going to come from your portal system, which we're going to go on to in a little bit. But just be aware that you've got arterial supply and you've got venous supply to your liver. So if we talk, let's talk about the gross anatomy, and if we talk about sort of more microscopic anatomy, so we've got our nice little lobule here, which is what it looks like. And then within each segment, we've got a bile duct, we've got an arterial, we've got a venule. And what's important to know is that you've got a contraflow system. So your bile flows from the centre, and it's going to flow outwards and down into your bile duct, and then drain through the biliary system. And then arterially, it's the other way around. So the blood from your arteries coming here, and it's feeding into here. As you can see from here, the supply from the portal system is also coming from the outside and draining in, because it's going to go through all this lovely filtering system of hepatocytes and other cells, and it's going to go out into your interlobular vein, which will eventually end up in your hepatic vein and then your IVC. So what have we got in terms of our liver cells? So we've got basically these plates of hepatocytes, which are nice liver cells, which have lots of function. A lot of them are to store iron in ferritin, and then also to do all of our other functions like production of proteins. We've got some other cells in there as well. So our Kupffer cells are the special liver macrophages, and they do phagocytosis of various things in the blood. So that might be abnormal pathogens, it might be old red blood cells, and those are located in your sinusoids. You've also got stellate cells, which are the cells responsible for storing your fat-soluble vitamins and only vitamin A, which are stored in lipid droplets. And then we've also got endothelial cells, which are going to line these vascular channels here. And they're the same kind of endothelial cells that you'll find in your vasculature throughout your body. Okie dokie, we're going to move on now. So I mentioned that we were going to talk about the portal venous system, and this is one thing that I always struggled to get my head around, because I thought, you know, that your arteries and your abdominal aorta gives off to all your arteries that supply all your viscera, and the vena cava takes all the veins. But a lot of the venous blood that comes from your lower GI tract and upper GI tract here is going to actually drain into your liver. So this is actually going to supply the liver with 75% of its blood from the portal system. So one of the liver's main functions, as we're going to go on to in a little bit, is to basically process everything that's absorbed in your GI tract. So it's really, really important clinically, as you guys go on to progress in your studies, to appreciate the portal venous system, because it has very big implications. So because so much blood goes from like your colon, your small bowel, your pancreas, your spleen, it also comes from your esophagus into your liver, all the things that are around here, such as could be cancer, can spread into your liver, which is why the liver is one of the most common sites for metastatic spread of cancer, because it receives such a huge amount of blood from all these other organs. It's also really important because this diagram doesn't really show it, and I apologise for that, but you also get a venous supply from your esophageal veins that are up here. And what that means is that if you get hypertension in this system, so if you get a build-up of pressure, then those esophageal veins are going to enlarge and they're going to form varices, which I think also appeared in your case with Michelle Ramsey, which is basically really, really dodgy because they can bleed quite badly and they can cause vomiting of blood, or they can cause melena, and you can actually get quite anemic from bleeding from your esophageal varices. So the reason you might get sort of a build-up of tension and get esophageal varices is because all of this blood here is going to go into your liver. Now, if your liver is not nice and flimsy and fresh, but it's a bit stiff and scarred and cirrhosed, you're going to have a lot of resistance of this whole portal that this portal system is going to meet. So what's going to happen is you're going to get an increase in blood pressure in this portal venous system. So that's why it's really important to be aware of the portal venous system and where all the veins come from, because it does have implications down the line. And also, if you think about it like a big gate, because porta means gate in Latin, which is quite nice. So yeah, that's the portal venous system. I thought it deserved its own slide for that. Okay, so liver function, and this is why I put it in a small single colon, because as we go on to later, liver function tests and liver function often tend to be two different things. So we've got some nice coloured boxes here. Bile, I'm going to be talking about that later in its own slide. So the liver produces bile. Bilirubin, so the liver is responsible for the processing, recycling of bilirubin and the conjugation of it. Synthesis of clotting factors, so the liver is responsible for making the clotting factors. especially your vitamin K dependent ones, which are 2, 7, 9, 10. So whenever you're thinking about down the line, when you start to think about things going wrong with the liver, always go back to thinking about what the liver does, because the liver does lots of things. So if you think about what the liver does, and then someone's got a problem with your liver, you can go back and think, okay, these are all the different things that now won't work. So one of them might be clotting factors. So you might have trouble clotting your blood and then have an increased risk of bleeding. Drug metabolism. So you can either get a drug that's metabolized to its active form, or you can get a drug that mostly if they're absorbed orally, so through your GI tract, and then through the portal venous system comes up to your liver, they can be metabolized to an inactive form, which means that their bioavailability, so the amount that's actually available in your system to do some work, is greatly reduced. So it's always good to be aware of the effect that the liver has, and that's first pass metabolism. Detoxification. So when people talk about, going on a detox and a juice cleanse, try and tell them that they don't need to do that unless they don't have a liver. And if they didn't have a liver, they wouldn't be alive. So just try and remember that your liver will be the thing that will be detoxing everything. And that's again through your portal venous system. So any kind of protein or things that you eat like that, that are not going to be used for anything beneficial to your body, they're going to be broken down. So amino acids that are not required, what they can be is they can be transaminated. And that's with ALT, so it's alanine transaminase, and AST. And that will result in keto acids and ammonia, which will then be recycled in the nitrogen recycling system. So your liver is going to break down those non-useful things and get them out of your body. So tell them to not to use their green juices anymore. Glucose management. So you had Jono earlier talking about the things that the insulin will do, and he mentioned that you're going to store your glycogen in your liver, and that's right. So about 100 grams of glycogen is going to be stored in your liver, and about 300 grams is going to be stored in your skeletal muscle. So your liver is responsible for gluconeogenesis as well, which is the creation of glucose. Now, I always used to get quite confused between glycogenolysis and gluconeogenesis, because I was thinking, well, they're the same thing, surely. You're breaking down glycogen to make glucose, or you're making glucose. So the difference is that gluconeogenesis is making glucose from non-carbohydrate sources. So that could be from things like lactate and other proteins. Whereas glycogenolysis is literally lysing, so that's breaking down the glycogen, making it into glucose that it can be used. So again, if your blood sugar is going low, we don't spend 24/7 eating, we might need a bit of glucose to get our brain through the day. And so what we might need is some glucose, but if we're not eating, we'll get some glycogen, we'll lyse it, and we'll get some glucose. Other things that the liver does is our mineral storage. So we mentioned before that hepatocytes also store iron in the form of ferritin. This is also important to note because if you have too much iron, it can be toxic to your body. And then nitrogen metabolism. So ammonia, which is a breakdown product from your urea cycle, is very, very toxic. It can cause problems with your neurotransmitters, it can cause lethargy, it can cause muscle cramps, lots of things like that. So your liver is responsible for turning your ammonia into urea, and then your urea can be excreted. So if you think about alcoholics or people who often have got chronic liver disease, and sometimes you might hear people be referred to as encephalopathic, which means encephalopathy. So they've got ammonia that's not been managed properly by the liver because their liver's faulty, and it's sort of impacting their brain and their cognition, and they're confused, and it's very, very dangerous. And it's a sign that the liver is really, really not very well at all. So moving on, protein synthesis. So your liver is responsible for making all these nice plasma proteins. Two that I'm going to mention in particular are albumin. So remember, going back to your sort of first few weeks of medical school, those two opposing forces that maintain fluids in your vascular space. You've got hydrostatic pressure and you've got oncotic pressure. So your albumin is going to be one of those main proteins that's going to exert oncotic pressure. And what that will do is it will draw fluid and electrolytes back into your intravascular space. So that's within the vascular system rather than in your sort of interstitium and within the tissues. And that's really, really important because you need to maintain blood pressure. If you drink a glass of water and you don't have any albumin, the water is going to be absorbed in your GI tract. It's going to go into your blood system, into your vascular system, and then it's just going to leak out into your interstitial space, and you're going to get really puffy, but you're also going to be incredibly hypotensive because you're going to have nothing within your actual vascular tree. So that's why albumin is really, really important, because it keeps all of that fluid within your vascular space. And then CRP, this is a lovely protein that you will hear banded about throughout your placement time. It's a non-specific marker of inflation, and it actually stands for capsule reactive protein. So as I mentioned before, the liver's in a capsule, and so when you get irritation for any kind of inflammation, you're going to get a raise in your CRP. So that irritation, inflammation can be from anything. It can be for having knee surgery, it can be from having abdominal surgery, it can be from being unwell with pneumonia. So it's very, very non-specific. So it's a good way to see, okay, is there something wrong? Is there an inflammatory process or an infective process going on in this person? Might do a CRP blood test, but just be aware that it's very, very non-specific. So if this person has got maybe a few things going on, the CRP might not tell you exactly what is going wrong, just that something is. And then finally, vitamin storage. So I mentioned before that your vitamins, especially the fat soluble ones, A, D, E and K, are going to be stored in your liver. And just to be aware, linking the two together, your vitamin K here and your clotting factors are linked, because those ones that I mentioned before are going to be 2, 7, 9 and 10 are going to be vitamin K dependent. So even though these things all seem like individual functions, they all work together to allow kind of your body to have that nice homeostasis. Moving on to the biliary tree. I love the biliary tree. I don't know why, but I just do. It's quite fun. I like drawing it. You'll be asked to draw it when you go on placement in sort of T year and P year, especially by surgeons. They always say, oh, can you draw the biliary tree? I think I've drawn it about 4 times across the years. So your biliary tree consists of your gallbladder, which is this nice sort of pear-shaped thing here. And from your gallbladder, it's going to store all your bile. So we've got these 2 ducts here. Your ducts are going to take bile that is made from the liver, go down, and it's going to be stored in here. And then when you eat, it's going to be secreted down your common bile duct. So common bile duct is the marriage of your cystic duct and your common hepatic duct. And then there, it's going to join your pancreatic duct, which is going to have some nice enzymes in it that your pancreas is going to make. That's going to come out through your ampulla of Vater. There's a little sphincter, and Don mentioned lots of sphincters in the body earlier, and one of them is your sphincter of Oddi, or Oddi, depending on how you pronounce it, which is then going to go into your duodenum. So what does bile do? So bile emulsifies fats for absorption, because otherwise it would just go straight through. We produce about 250 mL to a litre daily, depending on how much fat you eat. Whether you're a fast food junkie or a vegan marathon runner, you might produce different amounts of bile. So what is in bile exactly? So you've got your bile acids, you've got cholesterol, you've got phospholipids, you've got bile pigments, which is going to consist of your bilirubin and biliverdin that we're going to come on to later, some water and some electrolytes. Now your bile acid dependent parts of your bile are going to come from your hepatocytes, and your bile acid independent, which are the alkali components, are going to come from your ductal cells. So what happens? We make our bile, it goes into the gallbladder, and then it's stored and it's concentrated, because our liver is working continuously, but we're not eating fat continuously. So what we need to do is have somewhere to store it. So what it is it's stored in our gallbladder, and then we eat some fatty meal, maybe some McDonald's, maybe some nice chips, and we get a nice signalling pathway. So our duodenum is going to sense that fat, and it's going to release cholecystokinin, which is then going to signal our gallbladder to squeeze, and is also going to allow our sphincter of Oddi to relax, and a lot of bile is going to come out of our gallbladder and go in here. So this is a nice process. What could be possibly wrong with it? Well, this is my favourite cartoon, because it just reminds me that the gallbladder does not make stones. It just, well, it makes stones, it doesn't make bile. Sorry, I spoke wrongly there. So the liver is very important, and has a lot to do, as I mentioned, all those other coloured boxes with those things. And yeah, he gives the little gallbladder here some bile and says, hold this for a while, I'll tell you when you need it. And then she goes, oh my God, you made stones? You're just supposed to hold it. And says, the little gallbladder is very sad and says, oh, I just made these. So that's our biliary tree. What are some problems that can happen? So we can get our little gallbladder here making some stones, which can either be, you know, asymptomatic, you couldn't feel them at all, or they can cause some symptoms. Now, I'm not going to go too much into gallbladder pathology because you'll have a lot of that next year in T year in your IOD blocks. But it's just good to be aware, especially if you're taking a history from a patient in GP or something like that, to be aware of the problems that the gallbladder can cause. So we can get some stones and we can get some blockage. You'd think the two are the same thing, but actually you can get blockage from other things. So you can get blockage from within, or you can get blockage coming from without, sorry, from outside of the biliary tree. So that could be something like a tumour, could be something compressing it, and that can cause blockage. And if you can't get your bile out, and remember, part of our bile is our bilirubin, we're going to get it blocked off. And whilst the liver is producing bile, it's not got anywhere to go. It's going to go back into our liver and cause some problems. So, liver function tests. It's always a bit of a misnomer because a lot of the liver function tests don't actually test the function of the liver. So if you remember our nice coloured slide with all the boxes, those are the functions of the liver, but our liver function tests don't often test those things. So the good way to remember them is ALT, which is a liver test, the best way to remember it. And that is going to increase when you get damage to your hepatocytes. So that's the nice alanine transaminase, which is within your hepatocytes. So imagine your hepatocytes are a nice little sort of balloon full of this transaminase. Your balloon pops because it gets damaged and all the fluid leaks out into your bloodstream. And that's why you get a rise in ALT when your liver hepatocytes are damaged. AST, think of it as a second test, which is part of your liver function profile. ALP is alkaline phosphatase. Now this is slightly less specific because alkaline phosphatase can be raised with either gallbladder problems, liver problems, or it can actually also be raised because of bone problems. So if you have a bony metastasis or vitamin D problem, you might get a rise in your ALP. So next is your bilirubin, and your bilirubin can either be conjugated or unconjugated. It's always good when you think about bilirubin to always ask yourself, yes, it might be raised, but is it conjugated or unconjugated? And we'll go into jaundice and raised bilirubin in a moment. But when you're thinking about liver function tests, always ask yourself, is it conjugated or unconjugated? And then GGT, which the lovely Professor John DePark, or Dr. John DePark, I should say, always calls it gamma gin and tonic, and it's because it's supposedly raised in alcoholics, but it's not only raised in alcoholics. If your ALP is raised and you're suspecting a problem with your biliary tree, your GGT should also be raised because that indicates that there's biliary epithelial damage. And it might be from an obstruction, might be from alcohol, and it also can be raised in drug intoxication. When I say drug, I mean medication such as phenytoin, which is an antiepileptic drug. And then finally, part of your liver function test profile is your albumin. Now, your albumin, to be fair, is actually a marker of liver function because, as we said before, one of the liver's main functions is to produce proteins. Albumin is one of those proteins. But again, we might not know why the albumin is high or low if your liver's not producing albumin. Why is that? Have you got some kidney damage? Is your albumin leaking out through your kidney apparatus? There might be other reasons why. So that's why I've done a little gap here. And then these are some more actual functions of your liver that might be involved, but isn't part of the actual profile of a liver function test. So in my opinion, the best way to actually measure someone's liver function is their clotting. So we mentioned before that your liver is responsible for creating clotting factors. So your PT, or APTT, is going to measure your intrinsic and your extrinsic pathway. And I'm not going to go too much into that because that's part of your haematology week. But that's the best way to measure if your liver is working, because either your liver is making clotting factors or it's not. It's kind of, you know, is your PT prolonged? Is it not? Is your PTT prolonged? Is it not? Is it actually too short? Have your patient had too much warfarin, which is a medication that stops your blood from clotting? And then another one to mention that I will mention very briefly is your liver screen. So this is just a big profile of tests that you might do if you're not really sure what's going on and you're looking for anything that might affect the liver. This could be things like viruses, could be CMV, could be hepatitis viruses. It could also look for things like autoimmune conditions. It can also look for problems with congenital problems that you might be lacking an enzyme. So will be in your liver screen, and that's a huge long list. If you're ever interested in hepatology, you can go and look up all the conditions that are in your liver screen. And then finally, glucose. So I mentioned before that glucose is one of the parts of your liver function. So if you're suspecting that you've got maybe a patient who's not very well, has got a history of liver problems, they might become hypoglycemic because they're not eating. It might be because they're alcoholic and they've got an appetite suppression, and so their body is not doing that gluconeogenesis that I mentioned, or their glycogenolysis, where it's producing glucose from either glycogen stores, which might have already been depleted, or from things like lactate and other non-carbohydrates. So this lovely table here is from Geeky Medics. I highly recommend, if you struggle with liver function tests, to have a look at this. So in terms of patterns, I think it's really important to understand what each one is and why it might be raised before just memorizing patterns, because I think the danger with that is that you memorize a pattern and then what you're given in front of you is not a pattern that you recognize and you don't actually understand why something might be raised or not. So cholestasis is basically stasis of bile. And then what you might get, why are liver function tests might be normal with chronic hepatocellular damage. That might be someone who has been a long-term alcoholic, or they might have had a virus that's slowly destroying their liver. Your liver can compensate, and it can, be like, okay, so we're living with this hepatitis virus, cool, let's just get on with life, and it can adapt, which is why your LFTs might actually be normal if they've had a long-term problem, although it takes a while for them to adapt. So if the problem is acute, so if you've got acute poisoning, your LFTs are going to be off, which is why if you've got acute poisoning, say of your liver, your ALT, your A liver test, remember, is going to be really, really raised. Now, if you've got acute damage to your hepatocytes, so it's hepatocellular, then your ALP might be normal, but it might be raised, but maybe only slightly. So we like to think about your ALT being risen tenfold to make it really significant. In terms of your ALP, if your ALP is risen more than threefold, but your ALT is normal, it might be more of a problem with your biliary tree. Again, so if your GGT, your gamma gin and tonic, is normal, it could be normal, or it could be raised slightly. So do you remember we talked about your biliary tree problems and your ALP might be risen, but also your GGT might be risen. If you just have a rise in your ALP, but your GGT is normal, you might think about another problem causing your ALP to rise, such as problem with your bone. And then finally, your bilirubin. So your bilirubin might be raised a little bit with hepatocellular damage, or it might be raised massively, and you might see your patient as being quite yellow in front of you. Similarly with chronic hepatocellular damage, if you've got an alcoholic liver disease patient who's been drinking for a long time, their body might have adjusted to the high levels of bilirubin and it might be completely normal, or it might be raised slightly. But if you've got a problem with your biliary tree and your blockage, remember that our bile is getting blocked and we're not able to flow out of that nice tree. It's all going to be backed up into our liver and we're going to have a high bilirubin, which is going to cause jaundice. Jaundice and bilirubin. So again, this is slightly a crossover with haematology. So George always likes to talk about spiral learning. So it's a good opportunity for you guys to, in your heads now, just revise the life cycle of a red blood cell. So our red blood cell is going to be broken down into heme. From our heme, using heme oxygenase, the enzyme is going to be broken down into biliverdin. There, anyone who speaks French, green, just remember biliverdin, green. And then from there, biliverdin reductase is going to turn that into our unconjugated bilirubin. Our unconjugated bilirubin is going to be accompanied by albumin. Imagine albumin is like the big protein bouncer that has spotted some unconjugated bilirubin and is taking him to the door or the gate of the liver to become conjugated. Maybe he's going to sober him up or something. And it is going to become conjugated using an enzyme UDP GT1 or glucuronol transferase. Now, I know I'm mentioning these enzymes and they sound quite boring, but it is important because if someone is congenitally lacking one of these enzymes, this whole pathway is going to be disrupted. So we've got our conjugated bilirubin. It's been nicely packaged up and conjugated, and now we need to either get rid of it or use it again. So what we're going to do is we're going to pop it into our bile, and it's going to go out of our bile duct, and then it's going to go into our GI tract, where it's going to be urobilinogen. So urobilinogen is either going to be converted by bacterial proteases into stercobilin, which is the thing that's going to make our poo brown, or it's going to go into our kidneys and it's going to make our urine coloured. Now, remember that the conjugated bilirubin is water soluble, so that's what's going to affect our wee. If it's unconjugated, it's not water soluble, so it's not going to change the colour of our wee. Some of our bilirubin and our urobilinogen is going to actually be recycled back and absorbed via the portal system that we mentioned before, which is going to absorb all that nice venous blood from our lower GI tract. It's going to go back into the liver and it's going to be recycled again. So that's our lovely bilirubin pathway. Now, jaundice, got nice Lisa Simpson here. For those of you who've worked clinically before or volunteered and you've seen someone who's jaundiced, you will know. So if any of you haven't, don't worry about, oh, are they jaundiced? Are they a little bit yellow? Are they this? Are they that? You will pretty much know when someone's severely jaundiced. But remember that the bilirubin has a higher affinity for making the eyes jaundiced before it does the skin. So when you're doing your abdominal or your GI exam on someone, make sure to look at their eyes and take note of the whites of their eyes, because that's the first thing that will become slightly yellow. And yellow is probably the wrong term. It starts to look a bit sort of like dusky green. You might say, oh, they look a bit tired, and really focus on the whites of their eyes and see, is that actually yellow? So going on to our jaundice, we can either be jaundiced with unconjugated, conjugated, or a mixture of both bilirubin. And the way to work out what is causing the jaundice, because jaundice is not a diagnosis, it's a symptom. It's itchy, or it could be a sign if it's not itchy. So pre-hepatic jaundice, so that's before the liver. And that might be because of maybe an increase in breakdown of your red blood cells. Maybe you have sickle cell anemia. Maybe you're a little baby and you've got neonatal hemolysis. So there's lots of reasons why you might be pre-hepatically jaundiced, and that's going to be unconjugated bilirubin. And the worry with that, especially in babies, is that that is actually very unstable. You can cross the blood-brain barrier and could cause connectorus and seizures, which is why you see your babies, and I know you guys have done the baby case, so I know that you do know about this, your babies with the nice sunbed apparatus where it's having a nice UV light bath to try and conjugate jaundice. And then we've got intrahepatic jaundice. So this is a problem with maybe the conjugation, maybe there's a blockage somewhere in the liver, maybe it's cirrhosed, maybe it's inflamed and it's not able to perform its function of conjugating the bilirubin. And that might give you a mixed picture because it might be slightly able to conjugate, but also not. So it's important to note of the things that could cause it. And then post-hepatic jaundice. So this is when our bilirubin has been conjugated and now on the way out of this nice system here, something's blocking it, which is causing bilirubin to go into our bloodstream. So why might that be? And often it's because of a problem with our biliary tree. So it might be a stone, it might be an obstruction, something like that. So when you see someone who's jaundiced, go back to this diagram and think about where on this diagram the problem might be. Is it before the liver? Is it in the liver? Is it after the liver? or is it a combination of things? You know, it's always good to think about this, and it will help you narrow down what's causing the problem and then manage it appropriately. Okay, alcohol in the liver, our favourite thing coming up to Christmas, and everyone is getting merry. I don't want to alarm anyone too much, but yeah, alcohol is not good for the liver. We say in excess, but actually the guidelines did change recently, and we don't recommend that any alcohol is actually beneficial. So it used to be that kind of 1 glass of red wine can be recommended to reduce heart failure, heart disease, and things like that. But actually, recommendation now is that there's no medical benefit to alcohol that outweighs the risk. So I know this diagram looks a little bit scary, but just bear with. So we've got our ethanol here. That's our alcohol. So the main problem is that it's going to turn into acetaldehyde, and this is the problem because this is very, very, very toxic to our liver. Our liver is our detoxer. So if you've got something that's going to toxify your detoxer, it's going to cause problems with everything else. So normally your acetaldehyde is going to be converted to acetate via aldehyde dehydrogenase. But the problem is if you have too much alcohol. So that could be an acute intoxication where you can get alcohol poisoning, or it can be alcoholic liver disease over a long period of time. So acute poisoning, like poisoning from alcohol, is much less common because you tend to sort of lose your ability to drink more, or you start throwing up, or things like that, that actually stop you from drinking so much that you will become acutely poisoned with alcohol. But the kind of symptoms you might get are an increase in bleeding because your liver's no longer to do things like produce those clotting factors. Or you might get some jaundice as well because your liver's no longer able to conjugate. And then in terms of your chronic alcohol, you're going to get all of these problems. So firstly, our acetaldehyde is going to increase our acidosis. So it's going to make us more acidotic. It's going to disrupt our Krebs cycle, which is going to go here. We've got our pyruvic acid is going to go into lactic acid and is not going to go down this lovely cycle and go down here. Secondly, we're going to have lipogenesis, which is the creation of fat, which is why when people have sort of fatty liver disease, it might actually be from drinking. It might not be alcoholic liver disease, but it can be fatty liver disease, but it's also as a result of drinking. And we don't want too much fat in our body with all the problems that obesity causes. And then also, because of this, we don't get our nice glucose production from our glycogen lysis and gluconeogenesis, so we end up with hypoglycemia. So we've mentioned our fatty liver, we've mentioned our acidosis, and then we've also mentioned our hypoglycemia, and also our ketosis. So similar in the same way that you can get ketones generated from like a DKA, more of your acetyl-CoA is going to go into your ketosis rather than into your citric acid cycle. Okay, so that is kind of a summary of what the alcohol does and the sort of different pathways it can mess up. So in terms of your chronic liver disease, so that's over a long period of time, you're going to get problems with your liver function. So you're going to get problems with ascites, and that's fluid building up in your abdomen. And you'll see these people walking around, they look pregnant, but they're not. It's all fluid. And that's when you're doing your abdominal exam, you're testing for shifting dullness. So that is a combination of a reduction in albumin, which is drawing all that fluid into your vascular space. So instead it's leaking out, and then also portal hypertension. So your liver is nice and stiff from all the alcohol you've been drinking, and so that portal system is meeting a lot of resistance, and instead of going into the liver nice and smoothly, all the fluid's being pushed out into your abdomen. So some other problems that you can get is the varices, as I mentioned before, from your portal hypertension. Okay, so those are your main problems of alcohol and the liver. It's really important to mention because alcoholic liver disease is a huge problem in this country. You might not see it so much kind of in Tooting, but definitely in poorer areas, in the area I'm in at the moment. I'd say about 80% of our patients are on gastro rotation at the moment, and about 80% of the patients are coming in with really, really bad liver disease, all the signs that I've mentioned, as a result of drinking alcohol a lot over the years. And it's a very kind of poverty-based disease, because when you get poverty, you get increase in addiction and things like alcohol and smoking. And then because over time it's going to cause all this damage, you know, you get long-term problems, and then there's nothing really you can do except have a liver transplant once you get to the point where your abdomen is too big, and you're, you know, not producing clotting factors, not producing albumin. Your liver's really kind of packed it up and not able to do anything, which will eventually take your life, which is very sad. Paracetamol in the liver. So if any of you ever go to A&E, I guarantee that at some point you will see someone coming with a paracetamol overdose. It's very readily available in this country. You can buy it in Tesco, even though you're only supposed to buy a certain number of packs over the counter. I don't think anyone is really watching you if you go to one Tesco and then you go to a Boots and then you go to a Superdrug and then you go to a Sainsbury's and you buy pack upon pack upon pack of paracetamol, which is why you get people coming with paracetamol overdose. So paracetamol, normally when you take a nice therapeutic dose, so maybe 500 milligrams or maximum a gram, is going to go into this nice pathway here in the liver, where it's going to be conjugated, and then it's going to be excreted in the urine. A very, very small amount of paracetamol via the cytochrome P450 metabolism is going to be converted into NAPQI, which is a very, very toxic substance, but it's not that much if you have a therapeutic dose. So it's either conjugated with glutathione and it will then be excreted, because by conjugating it with glutathione, it will not become toxic. If you have too much, it will lead to hepatotoxicity. Now, the problem is with paracetamol overdose, it's kind of like musical chairs. So imagine that you've got, you know, 10 paracetamols and you've got 9 chairs. You've got 9 of the chairs going down this pathway, being used up and excreted, and maybe one of the paracetamols going down this pathway. The problem is when you take a lot of paracetamol, you suddenly got 100 people and only 9 chairs. So that means that 9 people are going to go down the normal pathway, and then you've got 91 extra paracetamols, people that don't have a chair. So basically, glutathione is going to get used up, and it's going to get used up quite quickly. So it's not there to help out when your paracetamol is converted to NAPQI. It's not there. And so instead, you're going to get loads more NAPQI because all your glutathione has been used up already. All the chairs have been taken. And so these 91 paracetamol people are just going to cause havoc on your liver. So what can you do? I'm sure you've gone over this before, but make sure to give N-acetylcysteine, which I'm sure in your PBLs you've gone over the paracetamol treatment curve, which is going to increase your availability of glutathione. And when you do that, you need to make sure that the paracetamol level is coordinated with the time in which they ingested the paracetamol, because that will dictate whether or not and how you need to treat it. So remember, when you're doing your paracetamol levels, that you have to do it after 4 hours of ingestion. So if they come in and they say I took paracetamol 30 minutes ago, your management is going to be slightly different. So what you're going to do instead, depending on how much they've taken, so you're going to do a really good history, make sure that they haven't taken too much. If they have taken what you deem as quite a lot, which is maybe about 150 milligrams per kilo, then you're going to start your N-acetylcysteine. Otherwise, what you can do is give them activated charcoal, but you can only really give that if it's very, very, very fresh to when they've ingested the paracetamol. So yeah, that is basically your paracetamol and the liver mechanism. If anyone's interested in this, it's a really great article, and it's from Life in the Fast Lane, which I'm sure you're all very familiar with because of its wonderful ECG teaching, but it does a lot of A&E stuff as well, and I very much like this table. So let's move on to some questions. I don't have the chat. Maybe I'll try and find the chat on my thing here. There we go. 25-year-old woman presents to A&E having swallowed 10 packs of paracetamol. So maybe that's a lot. The team takes her levels, say she's taken it, 7 hours ago, and she started on IV NAC, which is N-acetylcysteine. Which blood test would give the medical team the best indication of her liver function? So remember, we talked about the function of the liver and your liver function tests not necessarily being exactly the same thing. So what do we reckon? Do we reckon it's A, ALT, B, ALP, C, GGT, D, PT, or E, bilirubin? Ash is saying A. Any more takers? Do a little, should have a little timer, the countdown thing. Oh, sorry. Oh, yes, someone has mentioned A. Okay, so the answer is actually D. So what we mentioned before is the actual function of our liver. So the function of our liver is to produce clotting factors. And clotting factors, we can measure the production of them by using their PT, which is going to be their prothrombin time. ALT is going to measure our hepatocyte damage. ALP is going to measure hepatocyte damage and also biliary damage. GGT, again, biliary damage and some hepatocyte damage. And bilirubin is going to measure our levels of jaundice. So actually, none of those other four actually measure how well the liver is functioning and performing its tasks. Next. An intoxicated man stumbles into A&E on a Saturday night. This happens a lot in South London. He is very slim and looks malnourished. You can smell vodka, and he holds a bottle in his hand. Maybe he's hanging outside Sainsbury's. He appears lethargic, wanting to sleep, and then collapses, having a seizure. Which side effect of alcohol on the liver is responsible for this? And when I say this, I mean the seizure. So we have A, increased lipogenesis, that's increased production of lipids and fats. Got B, hypoglycemia. Got C, ketosis. We've got D, jaundice. We've got E, I should say hypo, not hyper, hypoalbuminemia. So, countdown clock. This isn't a clever question, by the way. This is a try and think about the most simple explanation, because yeah, it could you know. B, yes, hypoglycemia. So as John mentioned before, hypoglycemia is actually really, really dangerous. It will kill you. And our liver's function is probably quite messed up because this man is intoxicated. He looks slim and malnourished. So, you know, there's a chance that this man has got chronic liver disease and has now been intoxicated. And he's sort of seeming sleepy, wanting to sleep, so that might be a result of the ammonia on his brain. But having a seizure, that's probably most likely his hypoglycemia, because the liver is no longer able to produce glucose either from glycogen or from other non-carbohydrate substances to keep our brain going. Okay, select the correct bilirubin metabolism pathway. So we've got, I could read all of these out, but this is basically that diagram that I had beforehand of all the pathway of bilirubin going from your breakdown of your red blood cell all the way to either being excreted or being recycled. So I'll give you a while because it's a lot of bilirubins and billies that I've typed on the screen. Dun, 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 dun. Any more takers? So the answer is actually got an E. So our pathway is going to go biliverdin, so remember green before yellow, so that automatically excludes B, so we can cross B off. And then what happens before our bilirubin becomes conjugated? It's unconjugated, so then we've got C, D and E. left in the pool. And then what we're going to do is we're going to get unconjugated bilirubin. That's going to become conjugated bilirubin. So that's why E is not very nice, because, you know, I could have just left it out here. But after your unconjugated and then your conjugated bilirubin, is it going to go into urobilinogen or is it going to go into stercobilin? And the answer is C. So your urobilinogen is then going to become stercobilin, which is why E is incorrect, because it goes uro and then sterco, if you imagine it in that way. Okay. Which protein is responsible for binding to the unconjugated bilirubin and accompanying it on its way to its journey to the liver? So remember I mentioned sort of the bouncer finding some unconjugated bilirubin and taking it to the nice gate of the liver. Which bouncer was that? It's one of these lovely proteins. All of these are made by the liver. It just depends on which one is going to be the bouncer. Ten more seconds, 10, 9. Yes, albumin. So our albumin is our lovely protein made by the liver that has lots of functions. Yes, albumin, you're very right. So albumin is going to accompany our unconjugated bilirubin to the liver, it's going to escort it out of the club into the gate, and it's going to go, you need to sober up, my friend, and get conjugated. And that's what happens. So thank you very much for listening to that. I hope it wasn't too long and boring. I did try and make it as interesting as possible. The liver is the best organ in the body, in my opinion. I absolutely love it. And also at your stage in learning, the most important thing you can do is understand what the liver does, because at your stage you don't need to worry too much about investigations or pathology or management too much, because that will all come down the line. Because the liver is quite complicated, it's really, really important to understand the functions first, because then once you go through the years and you start to see problems with it, it will then inform why that person is having those symptoms, because they can seem a little bit unrelated, like, you know, if you smoke, you cough. Whereas with the liver, it's like, oh, if you drink, you bleed. Where's the, you know, the pathway of that? So that's why it's really, really important to, yeah, I'm a liver lover. I am a liver lover. I love the liver. But it is a bit of a nasty organ. It can really make you very, very unwell. Anyway, thank you to everyone. Any questions, please do get in touch. Thank you.
Hey, so hi guys, my name's Gi. I'm an F1. I'm working down in Torbay in South Devon at the moment, and I'm going to be talking about IBD today. So firstly, just a little bit of overall anatomy. So a recap of your small intestine. So your small intestine is divided into the duodenum, the jejunum and the ileum. The duodenum is the shortest part. It's about 20 centimetres long, but it's a big site of absorption. So you get absorption of glucose, amino and fatty acids, ions like calcium and iron. And iron absorption is facilitated by B12, which is produced in the stomach. Your jejunum is sort of the medium length part, and here there's sort of more things absorbed, and things like folate, more glucose, and more amino acids and fatty acids. And then your ileum is your longest part, so around 3 meters long. And really most of the vital nutrients have been absorbed by this point. But you do absorb sort of bile salts here. You reabsorb your vitamin 12 as well, and sort of it mops up any last nutrients that weren't picked up earlier in the small intestine. The blood supply is the celiac trunk, which comes off the SMA. And you can see here this sort of microscopic picture. You've got sort of mucosal folds in the small intestine that massively increase the surface area, and these villi, tiny little finger-like projections, it just gives a lot more surface area for all of these nutrients to be absorbed. Then you've got your large intestine. So your large intestine, by this point, most of your nutrients have been absorbed, but your large intestine will absorb sodium and also water as well, and sort of solidifies the stool as it's going through until finally it gets to the rectum, and it should be quite solid by then, all being well. And its blood supply of the colon is from the inferior and superior mesenteric arteries. You can see here on the left the sort of large structure of the colon, starting at the cecum on the right hand side, and then the ascending part going upwards, transverse that runs along under the diaphragm, and then your descending colon and your sigmoid, which is a particularly mobile part that's quite susceptible to twisting on itself like a volvulus, and then finally your rectum. So what is IBD? So it's an autoimmune disease which is characterized by inflammation of the GI tract, and it's broadly classified into two types, ulcerative colitis and Crohn's disease. In reality, in medicine, those two conditions are sort of very distinguished, but when you meet patients in real life, sometimes it's not quite clear which one that they've got. Some of the symptoms can overlap really in real life. But broadly for your exams, the main difference between the two, so Crohn's is more associated with upper GI symptoms because it can affect the entire GI tract from the mouth to the anus. So as well as diarrhea and abdominal pain, you're more likely to have vomiting, weight loss and fatigue. That's related to both the inflammation that's going on, but also the fact that it affects the small intestine and can affect the absorption in those areas, particularly higher up in the small bowel. And then symptoms of UC, it's pretty much always bloody diarrhea, because we're thinking of inflammation in the lower GI tract, and the blood is sort of red or dark red in colour to show that it's come from the large bowel rather than further up the GI tract. People also have bad abdominal cramps, urgency, tenesmus, which is basically a feeling of needing to pass stool but then not being able to, and this comes from the rectum being really inflamed and irritated. So we've briefly mentioned already, so Crohn's can affect any part of the GI tract. You can also get something called fistulas. So these are small channels that form between structures that are not meant to be connected. So you can get passages forming between the bowel and the bladder, or in women you can get from the bowel to the vagina. And of course, if you get stool leaking into those areas, it can cause infection, it can cause discharge, and it's really quite unpleasant for the patient. In UC, it always affects the rectum, and it will always start at the rectum, and then it kind of ascends round the colon in a sort of continuous wave of inflammation without any breaks. Crohn's, you can just see on that little bottom diagram on the left there, Crohn's tends to be patchy, and there's areas of healthy bowel in between the areas of inflammation. With UC, you can also get something called backwash ileitis. If you've got pancolitis, which is inflammation involving the whole colon, it can sometimes spread and just affect that very end of the ileum. And then if you're taking samples for histology and you're looking under the microscope, in Crohn's we would expect to see things like granulomas, and also inflammation that extends throughout the wall of the bowel. And in UC, we see just superficial inflammation, so involving the mucosal or submucosal layers. You see distortion of the crypts and polymorphonuclear cells, so cells that are sort of abnormally large nuclei. And then looking just with the naked eye on an endoscopy, you can see here on the left-hand side, the top picture is how a bowel should look. You can see it's very smooth. You can see some vascularity there. There's a small amount of stool and sort of at the top of the bowel there, but the rest of it looks just very healthy and normal. And then on the left hand side is Crohn's. So you can see, wait, no, I'm really sorry, I've got it the wrong way around. So on the right hand side is Crohn's, because you can see the cobblestoning there. So you can see the along the bowel, it almost looks like little stepping stone kind of lumps. That's what we call cobblestoning. And then on the left hand side, that's more of a UC type picture, where it's sort of superficial friable inflammation, and lots of shallow ulcers there. You also get what we call pseudopolyps in UC in the colon. So people with UC are more likely to develop bowel cancer in the future if they've got repeated inflammation going on and repeated healing processes. You've got a higher cell turnover, you're more likely to form sort of polyps, and eventually these can progress on to becoming cancerous. Okay, and then it's important to remember that IBD does not only affect the bowel, there's also symptoms in other areas of the body. So the eyes, particularly, you can get uveitis and episcleritis, particularly anterior uveitis. So inflammation of the superficial structures of the eye. You can get features in the mouth, so things like ulcers, which you can get in both Crohn's and UC, although it is more common in Crohn's disease. You get some liver conditions as well that are associated with IBD, particularly primary sclerosing cholangitis. And also you're at higher risk of gallstones as well. You can get some joint inflammation, either actual inflammation of the joints, so things like arthritis, or sometimes people just feel generally achy. That's less of a joint symptom, it's more of a myalgia kind of feature. You can get problems with the skin. So there on the bottom left is an example of pyoderma gangrenosum, often seen on the shins. And you can get problems with your kidneys as well, things like stones and UTIs. And some of this is related to the fact that people, have a lot of diarrhea. They're potentially quite dehydrated. If they've had sections of bowel removed or have a stoma, then they're even more likely to become dehydrated, so they're at risk of renal stones. So these conditions are all more likely to occur if the disease is not well controlled, and they often, get better as the patient's IBD gets better. There's also consequences of medication, so things like osteoporosis, if someone's been taking steroids long term. It has an impact on people's mental health, and it can affect sort of day-to-day life, particularly in younger patients. If they're missing school and things like that, it can have quite an impact. And it's really important to include sort of secondary care, obviously gastroenterology, but with specialist nurses as well, to help patients sort of day to day and be there for advice as well. So investigations that we would do. So obviously full blood count. So we want to look for iron deficiency anemia if they've got ongoing blood loss. You can get excess platelets in IBD, and it often ties in with higher levels of inflammation. We want to check electrolytes. These may be depleted if they've got an acute flare-up. CRP is a really useful marker of showing disease severity, particularly if the patient is in hospital and sort of having acute treatment. We can track the CRP and see how well that flare is responding, and how likely they are to need any surgical input. If they've got Crohn's, they're particularly at risk of being B12 and folate deficient, so it's important to check that. And then in the stool, we can test for calprotectin. So this is a really sensitive marker for IBD in particular, and the majority of patients who have got some sort of IBD inflammation going on will have a raised calprotectin. Of course, if a patient presents first off with diarrhea, we ought to want to do an MCNS just to make sure that it's not an infectious diarrhea. And then ultimately, if a person's got ongoing symptoms of IBD, we would do a scope of some sort. So if they've got predominantly lower GI sort of symptoms like the bloody diarrhea, we might go straight for a colonoscopy. Things like weight loss or nausea and vomiting, we might go for the OGD. And then here is sort of the stepwise medical treatment that we use for IBD. So this is kind of common to both Crohn's and UC. So we start off with very mild immune suppressant medications, things like 5 ACEs, like sulfasalazine, and also topical corticosteroids. So, for example, if someone's got ulcerative colitis that just affects the rectum, we might use an enema or a suppository rather than making them take oral steroids. If these don't work, then we might move on to oral steroids or immunomodulators, things like azathioprine or methotrexate. And then after that, you're looking at sort of more intense medication, things like anti-TNFs as a first line. There's also lots of other biologics now that are used for IBD. And then obviously as a very last line, if the IBD is particularly acute and not responding to treatment, or if someone's sort of gone on for a long time failing different types of medical management, then we might look at doing surgery. And this is just a flow chart talking about an acute colitis flare. So if someone comes into hospital and they've got features of acute severe colitis, so things like, you know, over sort of six to 8 bloody stools, they're, you know, tachycardic, they've got fever, you know, this is a sign of a severe flare. And initially the management is to give them steroids, either hydrocortisone or IV methylpred. And then we try that for 3 days. If it's not working, or rather if it is working, so if it sort of resolves their flare, their stool frequency reduces to less than 3 in a day, then we might switch them to oral steroids. And then when they're discharged, we might sort of review their medication. We could add azathioprine. If they're, you know, they're not quite responding, but they're getting slightly better, we may try a medical rescue therapy. So that would be a drug such as cyclosporin or an or anti-TNF, such as infliximab. And we do the same for non-responders, so people that just have not had any effect from the steroids, they're still going more than 8 times a day and their CRP is still high. And then if we try the biologic or cyclosporin and it still doesn't work, then we would look into doing an emergency colectomy. And often in emergency situations for UC patients, they'll do what's called a subtotal colectomy. And that is removal of most of the colon, but sparing the rectum. And that leaves a person with an ileostomy, and they have a rectal stump. This is because removing the rectum takes a lot more time under anaesthesia. It can take sort of 6 to 7 hours to remove the rectum because it's so surrounded by other structures. You know, particularly in women, they've got the ovaries and the uterus. We were on, if people are not complete responders, or they've not responded at all to the IV steroids, then we want to try things like cyclosporin or biologics. And if they don't work, we would look into doing a colectomy. And I was saying it would be a subtotal, just because it takes a lot of time under anaesthesia to remove the rectum. And if a person's acutely unwell, you just want to remove the majority of their colon that's causing their symptoms. And you can come back later and either remove the rectum, which will leave someone with a permanent ileostomy, or you can do what's called an ileoanal elastomosis or a J pouch, and that's sort of making a reservoir out of the small intestine and connecting that to the anal sphincter, which means the person doesn't have to have a stoma long term. This is only suitable, of course, for people with UC. If you try and do that procedure on people with Crohn's disease, there's a high chance that they'll get Crohn's in the new pouch that's being formed. And then lastly, just a quick word on IBS. So it's not on the lobs, but you know, IBS and IBD are quite commonly confused. Patients will sometimes confuse them. and and quite commonly general public will particularly. So IBS stands for irritable bowel syndrome, and it often falls into either IBS-D or IBS-C, either diarrhea or constipation dominant, and they also have abdo pain and nausea and bloating. It's not really well understood what causes IBS. It's often thought to be linked to diet, or can sort of flare up if people are under a lot of stress. But unlike IBD, there's no actual physical damage to the intestinal mucosa. The symptoms are very unpleasant, but if you were to scope somebody with IBS, there's no actual signs of inflammation, and a calprotectin test will be normal. So that's a really good sort of baseline test for somebody with bowel symptoms. If the calprotectin is negative, it's quite unlikely to be IBD. But if there's bleeding, however, sort of significant amounts of bleeding, and we've ruled out things like piles as well, then one of your top differentials is going to be IBD. Okay, so just got a couple of questions now to finish off. So 23-year-old visits her GP. She's got crampy abdominal pain, which is associated with loose bowel movements. She's got some blood in her stool, and she's referred for a colonoscopy, which shows continuous inflammation that starts at the rectum and ends at the hepatic flexure. So what's the most likely diagnosis in this lady? Yeah, we've got some people going for D. Yeah, exactly. So it is D. So, as we mentioned, blood in the stool is a real sort of key marker for it being UC. And she's got this continuous inflammation. UC always starts at the rectum, and there's sort of a clear end point, whereas Crohn's, is patchy and sort of stops and starts. And then this is a slightly odd one. So a mum brings in her 8-year-old to see the GP. She's worried that he's not growing quickly compared to his peers. He often complains of abdo pain. GP says that he's quite small for his age and he has a rash on both his shins. An endoscopy is performed and the stomach and small bowel look largely normal. So what is the most likely diagnosis? Oh, okay, yes, I can see some D's and some B's. Okay, so what I was actually going here for was B. This sounds more like a celiac kind of picture. But the reason I included this question is because it would be quite interesting to sort of differentiate between this being celiac or this being Crohn's disease. So some of the features sort of can overlap a little bit. So the rash, for example, I was kind of going for dermatitis herpetiformis, which would more go with celiac, but actually, we'd want to know sort of what sort of rash is it? Could it be like a pyoderma sort of rash, which would point more towards Crohn's? And also in children, Crohn's can cause things like failure to thrive. It can also obviously cause abdominal pain. And the stomach and the small bowel looking largely normal, that's reassuring, and that sort of points us more to celiac. But a standard endoscopy would only sort of see the stomach and the duodenum. And the Crohn's, if he does have Crohn's, could be sort of further down in his small bowel. So I think, obviously we'd have to do further investigations, but this is just an example of sort of showing these conditions can overlap, and just to be a little bit careful in exams as well. Okay, and that's the end of my slides. Does anyone have any questions?
Oh, hello. This is the recap talk for Kidney Week. Just a quick disclaimer that I really hated this week at the time. I remember it very vividly and thinking, what on earth was I supposed to get from this? And I remember thinking at the time, oh, okay, well, if it was all really hard to get, hopefully that means it's actually like a relatively small amount of knowledge we need to know. And that was a bad assumption. I did really badly in the exam in first year. And then actually when we came back to it in T-year, I did get a lot better. I felt like I really sunk my teeth into it a little better and realised that actually the teaching in year one is not great. And they don't do a very good job of focusing you on the basics of the kidney, which is what I'm really hoping to do today. So if you encounter anything that's outside of this, hopefully you can just tuck it away and not think about it, because you don't need it for year one anyway. If you know this stuff that I'm about to go through on a basic level, you'll be absolutely fine for year one and probably for the rest of medical school as well, because the kidneys just are involved with absolutely everything. They come up all the time. Cool. Okay, so basic functions of the kidney. Kidney has 4 very basic functions. I'm starting with this now. You'll have already gone through this before, but I'm just starting with this now because it's just a really, really good baseline for for everything that comes up in the kidney. It's just good to have these 4 things in your head. So 4 basic things it does are regulate water balance. So it controls how much water you're passing out of your body, and if you need to conserve water, it will do that. So it will make you not release as much water. It regulates your electrolyte balance. So there's loads of different electrolytes, sodium, potassium, loads of different sort of things that the kidney can finely control using various different hormones and mechanisms, how much is going in and out. It can regulate the waste in your body. So this is things like urea, which you don't need. It's a breakdown product from protein, and the kidney will help you get rid of that. And it's one of the things that helps regulate your acid-base balance, so how acidic or otherwise your blood is. And if everything's getting a little bit too acidic, the kidney can help out with that, and vice versa. And likewise, if it's too basic, it's too much for, I'm not going to say that. If it's too basic, the kidney will help out as well. And it also has a couple of other functions which aren't as important in year one as those core 4, but I thought I'd just briefly mention that obviously it helps control your blood pressure, and we'll come back to that a little bit later because that is important, and you'll already come to that already. It helps activate vitamin D, which is it just pops up everywhere, vitamin D. It sort of helps you get your calcium and your phosphate levels right, and the kidney, without your kidneys, vitamin D goes a bit haywire because you can't make it. And then it also helps you stimulate your red blood cell production through a hormone that it releases called EPO. And again, not super important for year one, more for chronic kidney disease, which you'll learn a lot more about in year 2. Year 1, the focus is much more on the sort of acute kidney injury and sort of what to do about it. So yeah, remember these core 4 things. I'll tell you why you need to remember them, because I'm about to tell you what happens to them when it all goes wrong. So again, apologies, this is really basic. Skip over this bit of the talk if you already know all this stuff. But so, like I've just said, these are all the functions of the kidney, and when it goes wrong, boom, knock out the water balance, and you're going to get problems in the body related to too much or too little water. So if the kidneys are not getting rid of enough water, you're going to get fluid overload in the body. You're going to get swelling, edema, possibly pulmonary edema, fluid where it shouldn't be. Maybe oliguria, you're not passing enough urine because the kidneys are holding on to too much water. Or vice versa, you can get rid of too much water if the kidneys aren't working properly. So you can lose too much fluid volume in your body, you can get hypovolemic, or you can pee too much urine out, polyuria. So if you knock out the kidney's ability to regulate electrolytes, you will get things like hyperkalemia, which is the big nasty electrolyte imbalance when the kidney's involved. There's other things that can happen as well, but for JEP year 1 and basically for the whole of medical school, if you think of something wrong that can go with the kidney and electrolytes, think of hyperkalemia, because that's the big one that will kill you quite quickly if it gets out of control. If you knock out the kidney's ability to regulate waste excretion, you get a buildup of waste. So things like creatinine, which is a waste product that your body produces from sort of muscle breakdown, you don't need it. And so if the kidney can't get rid of it, it goes up in your bloodstream. Likewise, you don't need urea either. And if you can't get rid of it, that'll go up, shoot up as well. You get uremia, and you can get symptoms from uremia. It can make you very nauseous, and it can make you very itchy all over. It can give you sort of, when it gets really, really bad, it can affect your brain. You get encephalopathy. You can like lower your GCS score. It's not very nice. Yeah, so that's something to bear in mind. And then if the kidney can't regulate acid-base balance, the big problem that results from that is you get metabolic acidosis. You can get a lot of other acid-base balance problems as well, but that's the main one, again, with the kidney and with an acute kidney injury that you might want to watch out for for the purpose of JEP1. So those things, I just think that's quite a nice way. That's the way that I think about the kidney. I just always think of those 4 things and what the actual practical problems are when those 4 things go wrong. So I won't go through this in a huge amount of detail because I'm not an anatomy teacher, but hopefully you're all familiar with this picture of the kidney and what all the different bits of the kidney are. They're not going to ask you anything much more complicated than this in the anatomy exam, and if they do, don't worry about it. Just look at the question, sigh, and move on. And this is the nephron. I find this picture really nice because a lot of the pictures of the nephron are just, it's sort of all in one line. Whereas this is more accurate as to what the nephron actually looks like when it's in the kidney. So it's all kind of bunched up a little bit. So you've got the glomerulus inside the Bowman's capsule here. You've got the proximal convoluted tubule, the first bit here. You've got the loop of Henle coming down here, and as part of that, the descending limb, and going up again, the ascending limb. Can you see my mouse, by the way? I'm assuming you can. maybe we can't. I'll try not to use it too much. Okay, so and then after that you've got the distal convoluted tubule, which is sort of the last bit before it hits the collecting duct just here, and then it drains out of the collecting duct and into the renal pelvis, into the calyces in the renal pelvis here. And you can sort of see in this diagram how literally that, this is where the nephron is, and it sort of filters out here, piles down the ureter here, and it goes into your bladder. So I think that's just a nice practical way of looking at it. You don't have to know the anatomy of the nephron too much more than that, I would think, throughout most of your medical lives. So I wouldn't panic too much about getting more complicated than that. Okay, so I've waffled on for ages. Let's do some questions. So have a read of this one. Does anyone have any ideas what the answer to this is? Any takers? Oh, I actually just realized I'm not checking the chat, which is what I should be doing. So give me a second and I'll log in on my other thing.
I'll read it out to you right now. There's a C, there's a B, and a D.
Amazing. Okay, so none of you have got the right answer, but good tries, because this is a hard question. So the point of this question was that most of the reabsorption in your kidney, just by default, happens in your proximal convoluted tubule. So almost as soon as everything comes out of the blood, it goes straight back in again. The proximal convoluted tubule is an absolute workhorse, and it does most of the job of reabsorbing your water and your electrolytes. Everything else that happens in the kidney in all the other areas is that's more of a fine-tuning process of adjusting how much happens in each area, how much you're absorbing and how much you're excreting in the urine. But the proximal convoluted tubule basically kind of rumbles on, and not much changes in how it does its job, which is reabsorb loads and loads of water and electrolytes and glucose and things. Does that make sense? Cool. So, second question. Okay, don't be freaked out by the fact it's got osmolality in it. Let's see if any of you have got some decent answers for this one. Okay, so someone has said A. Someone has suggested D. And actually, I have to give it to A. That is the correct answer. So this is again a really hard question, because there's a lot of different parts of the kidney that do a lot of different bits with regards to reabsorbing or secreting water. But basically, this athlete has been lost in the desert for hours and hours and hours without any food or water. So his body's been desperately trying to conserve water. And in the kidney, the biggest part that makes that happen is in the collecting ducts and the distal convoluted tubule, and it's this hormone called ADH. So while there are other sort of reabsorption bits happening elsewhere in the kidney, the major effect of your urine, the major part of your concentrating urine, is your antidiuretic hormone, your ADH, and your collecting ducts and your distal convoluted tubule, and that's the bit that will really stop you from weeing if you need to conserve water. And so that's like quite a nice fact, because I remember that coming up in an exam previously, and also it's one of these things that pops up on online question banks if you're partial to such things every now and again. So yeah, your big sort of take it or leave it hormone is your ADH, and that will really control how much water you're passing or not. Okay. So the other thing with that question is it mentioned high osmolality, and I just wanted to remind you, because I used to find this very confusing, that when osmolality is high, there's lots and lots of osmolality. That means that there is basically the solution is very concentrated. It will pull in loads of water, i.e. it's very salty. And very low osmolality means it's very not concentrated, i.e. it's very watery, and there's not a lot of solute or salt in it. And it's good to sort of get those things wedged in your head, because annoyingly osmolality does come up when you're a doctor. It's not just one of those like frustrating things. I was on placement this week and people were talking about paired urine and sodium osmolalities, and I was like, oh, didn't I leave this all behind in Jet 1? No, it is actually important. So I'd just put this here as a reminder. And this is a sort of diagram of what ADH does. So this powerful hormone I was talking about. So when you are needing to conserve water, i.e. you've been running around in the desert for 10 hours without any water, which is a very silly thing to do, your kidneys will, you will get ADH acting on your kidneys, which is this hormone that inserts these aquaporin channels into your collecting duct. And basically what that does, it just literally allows the water to run through that aquaporin channel back into your sort of kidney and your bloodstream. So it doesn't go out into the ureters and into the bladder and then obviously out as wee. So it's all going back into your body rather than coming out. Hopefully that makes sense. Cool. So another practice question. So Jackie, the nephrologist, I's head is back again. I think I've swapped around the order of these questions, so apologies. But basically, she wants to quiz the F1s treating her, and she's asking which of these drugs acts primarily in the distal convoluted tubule. I'm very sorry, this is a horrible question, and I will explain it. Okay, got some answers coming in. Got a D, lots of Ds, and you are all right. Yes, it is indapamide. Well done. Thiazide-like diuretic. So different drugs act on different bits of the nephron to have their effect, and it's just a good thing to remember that indapamide acts in the distal convoluted tubule for basically no reason other than the fact that they like to ask you about it in questions. I will come back to this later, so don't worry. In fact, I'll come back to this now because I forgot that this is where I put this diagram, which, by the way, this diagram, which I made myself based on a few other diagrams, I kind of put them together. This will kind of save your life when it comes to the kidney. This is what I think of every time I think of the kidney. So this is, hopefully you can see the nephron. So you've got the glomerulus here at the start. So if you just break the kidney down into these 5 portions, and you can also say which drugs act in each of those bits. It's just, I cannot tell you how high yield this slide is. This is my favorite thing. I come back to it all the time. Apologies, I'm a massive loser. So blood is ultrafiltered through the glomerulus. So this is the capillaries, goes into your glomerulus. into filtrate, and the rate that happens per minute in both your kidneys, that is your glomerular filtration rate, so your GFR. So if you've got a very high GFR, and that means that you've got lots and lots and lots of filtration happening per minute. And if you've got a low GFR, you're filtering very little per minute. Generally, it's good to have a decent amount of filtration going on. We don't like it when your GFR drops too much. So your glomerular pressure is decreased by NSAIDs, so non-steroidal anti-inflammatories, and by ACE inhibitors. So basically, these are two drugs that act on the afferent and efferent arteriole in the sort of glomerulus complex. And basically, all you have to know is that they both reduce GFR. So they'll both reduce your filtration rate in your kidneys, which most of the time is a bad thing. So if you have any kidney problems, like an acute kidney injury, you want to stop giving people ACE inhibitors and NSAIDs. There are exceptions, but you do not have to know there's exceptions in Chapter 1, so do not panic. As far as it goes for you guys, NSAIDs and ACE inhibitors, stop when there's kidney trouble. Okay, so next, moving on to the proximal tubule, you've got most of, like I said, most of your electrolyte and reabsorption happens here. 90% actually of what comes into the tubule goes straight back out again in the proximal convoluted tubule, because we need most of it. And importantly, your glucose is reabsorbed here, and as Jono has talked about, or will talk about, depending on what order this is put in, this is reabsorbed here through Sgl2 Sgl2 channels, Sglt2 channels, and so Sglt2 inhibitors like dapagliflozin and canagliflozin and anything ending in gliflozin, they work here to reduce your glucose reabsorption. I.e. so they sort of stop your Sgl2 channels from working, so your glucose actually stays in the tubule, and more of it goes all the way down the tubule into the collecting ducts and out into your urine. Less of it is reabsorbed into your bloodstream, so you get more glucose excretion, so it can lower your blood glucose, those drugs. So that's just a helpful thing to know. They act here, proximal tubule. Loop-of-Henle. Okay, so you might have heard of loop diuretics. That's where these drugs work. So again, even though the majority of water is reabsorbed here, there's some fine tuning that happens here. So when your body needs to, it can reabsorb more or less in the loop of Henle, and it can use this loop to do that. Loop diuretics block the sodium potassium chloride pumps here in the thick ascending limb, and that results in more water excretion. I'll briefly explain that a bit more, but you don't need to know a huge amount more than that, I would think. Don't panic. Distal tubule. Okay, so some of you might know because we just did the question, and if you're really paying attention, you know that the thiazide diuretics work here. And again, this is sodium and water reabsorption happening. It's again kind of like fine tuning. The body can do more or less if it wants to, and this largely happens through these sodium chloride channels, which thiazide-like diuretics block, and therefore more sodium and more water stays in the tubule and goes out into your urine. And then lastly, you've got your collecting duct, where a few things happen, including, like I said, ADH acts here and gets loads of your water reabsorbed when needed, and also quite a lot of your acid-base balance stuff happens here in the collecting duct as well. So if you need to, you can hold on to or lose more hydrogen ions or bicarb, and your kidney's got a very complicated mechanism for retaining bicarb, which, to be honest, I think Seaman Rice tries to teach you. I would just forget it. I don't think you really need to know it. I don't bother. But it also does the water reabsorption, like I said, through ADH, the action of ADH, introducing those aquaporin channels. Also, crucially, this is where aldosterone acts. So you might remember aldosterone makes its first appearance in your lives in the renin-angiotensin-aldosterone system. And from there on, it basically doesn't leave. Aldosterone is very important. And this is where it acts to, and the action it has is to cause your collecting duct, cause your kidneys to hold on to salt. And it does that by swapping it with potassium. So aldosterone says, great, we're going to hold on to all this salt, and therefore we're going to hold on to loads of water, because remember, wherever salt goes, water follows. and we're going to, in exchange, get rid of some potassium. And so there's a kind of diuretic called aldosterone antagonists, which block the action of aldosterone and therefore stop aldosterone from retaining sodium. And if you stop aldosterone from retaining sodium, you'll lose loads of water as well, because the water will follow the sodium. So you'll excrete the sodium, excrete the water, and you'll hold on to more potassium in exchange, which is important to note as well. So this, just, I don't know, pin this up on your wall somewhere. I'm going to toot my own horn about this one. This is, I mean, I should really charge for this. I wouldn't, because I think charging for medical education is borderline unethical, but that's a discussion for another day. Let's move on to another question. See, this is the question that's supposed to come first about Jackie, the nephrologist. I apologize, it's very poorly managed. But she presents to A&E with oliguria, and because she's bored, she quizzes the F1s about her suspected AKI. So which part of the renal tubule is impermeable to water? So which part of the renal tubule is the only bit that water cannot pass through either way? Got some A's coming in, and you are all right. Yes, well done. It's the ascending loop of Henle or the ascending limb of the loop of Henle, either way. Now, this just requires a very, very basic understanding of how the loop of Henle works. This diagram is horrible. All diagrams of the loop of Henle are horrible. I'm really going to try and make it as simple as possible by just saying that basically the ascending limb, this bit here, sort of the second bit of the loop of Henle in as far as water goes. This bit is the bit that sets up the concentration gradient. It does that by actively pumping out sodium here through these sodium channels, through these active transport channels. So it pumps out the sodium into the sort of interstitial space here, and it sets up this concentration gradient. And so it starts off salty here anyway, and as you go down further into the loop of Henle, it gets even more salty, and it's very, very salty at the bottom. So this means that as water goes down here, so these numbers here are the osmolality, so there's quite a low osmolality here, which means that water is not very concentrated. And then because it moves here and suddenly there's lots of salt here on the outside, the water goes, oh, okay, lovely, I'd like to go where the salt is. So some of the water leaves here, which means this bit is a bit more concentrated. Then some of the water leaves here, and this bit becomes a bit more concentrated. And then some of the water leaves here, becomes very concentrated down here. And that is all possible because the ascending limb sets up this concentration gradient and maintains this sort of line of sort of saltiness in descending order. And so this ascending limb here, all it's doing, its only job is pumping out salt. It's not taking in any water, and so it's impermeable to water. If it was permeable to water, I think it would mess the whole thing up. So it's got one job. So just think about it in that way, if possible, if it helps you. If it doesn't help you, ignore that slide, move on with your life. That's okay. It's okay by me. So another practice question. So which of the following drugs should be stopped in an acute kidney injury? Okay, so I've got some D's coming through on the chat, and that is exactly right. Amazing, well done. This is one of those things that by sort of year 4 or 5, you'll have answered this question so many times on PassMed, it will just be a bit of a reflex. But for you guys, it won't be, and that's absolutely fine. So ACE inhibitors, as I said before, in an acute kidney injury, are no good because they reduce the GFR. There's a really nice diagram actually that I've completely nicked from Professor D'Oliveira, so all credit to him. This is a great little animated diagram here. So you've got the glomerulus here, you've got the afferent arteriole arriving, because it begins with A, so it arrives here. The blood comes in this way, gets into the glomerulus, and then F's off through the efferent arteriole on this side. So it leaves through the efferent arteriole. And as you notice, the afferent arteriole generally is wider than the efferent arteriole, and that is to maintain that pressure gradient so that blood is filtered through the glomerulus like this. So if you have add in the effects of the drugs like this, so an ACE inhibitor, an NSAID, ACE inhibitor, for example, I think is first. So ACE inhibitors will dilate your efferent arteriole. So in dilating this arteriole, there's now less of a pressure difference between afferent and efferent. So more of the blood is going to go away through the efferent arteriole, and less of it is going to be filtered through the glomerulus. So that will lower the amount of filtration, will reduce your GFR. And very similar effect will be had by NSAIDs through a different mechanism. So the NSAIDs, because they inhibit prostaglandins. Prostaglandins generally dilate things, and so if you get rid of prostaglandins by using NSAIDs, they will constrict your afferent arteriole, and so by doing that, you've got less blood arriving through the afferent arteriole, and therefore less blood is going to be filtered through the glomerulus, and so it will reduce your GFR. So that's a sort of picture way of thinking about it. This kind of confused me for a while, sort of afferent pressure differences and stuff. The whole pressure thing I never did physics, so it kind of bamboozled me, but someone explained it to me like this, which I really liked. If you think of a hose pipe with holes in it here, so you've got holes in it here, the water's gushing out, and the water is flowing this way along the arrow, so it's coming along here left to right. So this water, these holes here, this is your glomerulus. And if you stamp a foot down here on this bit of the hose pipe, the afferent bit of the hose pipe, what's going to happen to these water jets? Are they going to get bigger or smaller? They're going to get smaller because less water can arrive to squirt out of them. On the other hand, if you stamp your foot down on the right side of the holes, so in the efferent side, what's going to happen to these jets of water? They're going to get bigger. More water is going to squirt out of here because less of it can leave through this way because you're blocking off that way. So more of it is going to squirt out this way. So just think of these holes in the hose pipe as your glomerulus. If that helps you, great. If it doesn't, as usual, please ignore it and move on with your life. Cool. So let's answer this question about Helena. What do you think the most appropriate management for Helena is? I'll let you read that for a little bit. Okay, so got some answers coming through in the chat. Someone suggested D could be beneficial. I'd just like to say that D is not a joke answer. They actually do use well, not acupuncture, but they do use transcutaneous electrical nerve stimulation, which is basically like acupuncture, for various forms of neuropathic bladder injury. I used to work in urology clinics, that's how I know that. But yes, the answer to this question is not D. It is in fact C, which is IV fluid resuscitation for ischemic injury to the kidney. And how do we know this from this question? There's several clues that this is a pre-renal or ischemic injury to the kidney. She's a nurse. Whenever there's a nurse in a question about the kidneys, you're thinking, oh my goodness, she's worked really hard all day, she's on her feet, she's not drank anything, she's been too busy. Hot tip. She's also tachycardic, a little bit confused, and most importantly, she's got dry mucous membranes, i.e. she's dehydrated, she's hypovolemic, and she's got a postural drop in her blood pressure, which means that when she lies down, her blood pressure might be okay. When she stands up, her blood pressure drops, and that's literally because blood is sloshing around in her because there's not enough of it, so she's hypovolemic. So that is your biggest clue, that she hasn't got enough blood going to her kidneys, and that's why she's got an ischemic injury to the kidney. Ischemia just means not enough blood. And if that is confusing, we will just quickly go through the different types of acute kidney injury now. You've already been taught about this, so I won't go through it in a crazy amount of detail, but I'll just tell you the things that I find helpful when I'm thinking about this. So breaking it down, you've got pre-renal kidney injury. So the problem with a pre-renal injury is that your kidneys are not getting enough blood to function. Basically, the kidneys love getting blood. They get 20% of your blood, all of the blood from your heart, every minute. They need blood to keep going. They need their blood to function. If they don't get enough blood, they won't function. And that's what happened to poor Helena in the last question. So your clues in any question that suggest a pre-renal kidney injury are any signs of hypovolemia, so sort of postural hypotension, dizziness on standing, fast heart rate, any excessive loss of fluids through like diarrhea or vomiting, any indication they haven't been drinking enough fluid, so like that one previously, that other question previously where that chap was running around in the desert and he hadn't drank anything for ages. That is obviously low fluid intake, and renal artery stenosis. So that's literally just a narrowing in the arteries that go to your kidneys, so that you won't get enough blood flow to your kidneys. So that's pre-renal injury, by far the most common cause of acute kidney injury that you'll see in sort of exam questions and in real life, which is good. Intrarenal injuries. So the problem here is the kidney itself is damaged. The kidney is made up of lots of different parts, obviously. The bits that we are sort of thinking about are the glomerulus, the tubule of the kidney, which is obviously lined with those sort of tubular epithelial cells, and the interstitium, which is sort of the bits in between everything else. So it's everything outside of the tubule, basically. So the clues in your question for an intrarenal kidney injury are, if anything mentions acute tubular necrosis, that is by default an intrarenal injury. The clues for that, if they don't spell it out for you, are if they mention anything about epithelial casts in the urine or muddy brown casts. If you ever see muddy brown casts, either in real life or an exam question, that is by default definitely acute tubular necrosis. That is exactly that is just these tubular cells lining the tubule that have just died and slid all the way down the tubules into the urine, and you get this muddy brown cast in the urine. If you also get hematuria or proteinuria, so blood or protein in the urine, that indicates there could be some damage to the glomerulus, so could possibly be some sort of glomerulonephritis. Don't worry too much about this because this is definitely second year, third year stuff. Or you could have peeing loads, so polyuria, and this is often after loads of your tubular cells have died and you're recovering, so you're giving loads of fluid to the kidney, but because your tubular cells are dead, they can't reabsorb any of the water, so you just pass loads of it out. You just lose loads and loads of fluid. All type of acute kidney injury is your post-renal injury. So this is anything that happens after the kidneys. So there's a downstream blockage that makes water water backs up into the kidneys. And as much as the kidneys love blood coming in, they don't love water blocking off and backing up the other way, because that will ruin the flow and it will make the kidney not be able to do its job, and it'll put loads of pressure on the kidney, and the pressure will make the kidney cells die. So not good. And your clues in the question are anything sort of in the ureters, in the bladder, sometimes in the urethra, anything like that that is a blockage that will stop the flow of urine out when you pee. So enlarged prostate, palpable bladder, because the bladder's got really, really big because it's in retention, or a kidney stone sometimes can cause this problem, or a type of bladder or urothelial cancer. So don't have to know a huge amount about each of those individual things, just know the sort of syndrome of how a post-renal injury would present, i.e. With someone who hasn't peed in a while, and he's got massive swollen kidneys. He's got what's called hydronephrosis, where the water is just backed up into the kidneys and made them really swollen and horrible. So yeah, that's what I need to say next. So the important thing to note, which was again really badly explained to us in first year, is that both a pre-renal and a post-renal acute kidney injury can actually cause an intrarenal kidney injury. So you can get a bit of both going on, and that is because both of these things can cause the tubular cells to die, and so that will so both of these things, so ischemic injury to the kidney and a downstream blockage, they can both cause acute tubular necrosis. So then one problem kind of causes a second problem, and then you've got two problems. The kidney's in trouble and something else is happening. Either it's not getting enough fluid or it's there's a blockage downstream. And something that I haven't said is that the way that you diagnose an acute kidney injury is by looking at your USNEs, your blood results, and you either see massively raised creatinine above what it should be, because your kidneys should be able to filter out creatinine, and like I said before, if they can't do that, that's a sign of kidney damage. Might see raised urea, because again, it's the waste product. You might see a reduced GFR, so the kidneys aren't able to filter as much. Often you'll see they're passing less urine because the kidneys are not able to do their job properly. The exception being, like I said, after they've been damaged, where they can get this polyuria. Hopefully that makes sense and I haven't just bored you to tears. That is a nifty little sort of thing I help to remember these things. And the management of these things, oh God, I remember really struggling with this, but basically it's relatively straightforward. So your general management of acute kidney injury, stop any drugs that are bad for the kidney. So like I've said, NSAIDs, ACE inhibitors, gentamicin is an antibiotic that the kidney absolutely hates. It can cause loads of horrible things to happen. So stop that. Supportive treatment. So basically monitor these things, monitor the pH, monitor the water input and output, monitor your electrolyte balance. So yeah, monitor your USNEs, urine output, urinalysis, ask them about any drugs they're taking. And if you don't know what the cause is, if you don't know whether it's pre-renal, post-renal or intrarenal, do a renal ultrasound, why not? Or ask a friend who can do it to do it, because that'll identify any blockages. It can identify the sort of swollen kidney, like I said, the hydronephrosis, and it can sometimes identify sort of echogenic kidneys or damaged kidneys. And more individual treatment for the different types of acute kidney injury. Most of these are give fluids because the kidney loves fluids. So give fluids for a pre-renal injury because the problem is it doesn't have fluids, so give fluids. Intrarenal, you want to support the kidney while you find the cause of the intrarenal injury and fix it. And what does support the kidney involve? It involves giving fluids. So that is pretty much what you want to do. And for a post-renal injury, obviously this is the one where giving fluids might not help and might make things worse, because if there's a blockage, you're just going to make the kidney more swollen. So the way to fix this is find the obstruction and get rid of it. And you'll learn more about how to deal with an acutely obstructed sort of kidney next year. But for example, if you've got benign prostatic hyperplasia, which is when you get a massive swollen prostate and that's blocking the urine outflow, you can get a catheter in through that sometimes, so the urine can flow out, and that will ease the pressure off the kidney. I hope that makes sense. Any questions, please do send them in the chat, or email me. My email address on the first slide. Cool. Okay, Hans needs some help. So on inspection of his blood results, after you've inspected his blood results, which of these electrolyte abnormalities is most likely? So I'll give you a clue. You can probably do this without looking at the blood gas, actually, just by way of there being a horrible acute kidney injury. Someone said A. Could they be right? Yeah, they're right. It's hyperkalemia. It's always hyperkalemia when it comes to the kidneys. Too much potassium. The reason why I mentioned this blood result, because you can see from this pH they're acidotic, and you can see from the bicarb that the bicarb is low. So you can tell this is a metabolic acidosis. You can also see that the CO2 is low as well, so they're trying to blow off the acid that way. So metabolic acidotic picture, and the electrolyte imbalance that is most associated with is hyperkalemia. This is because, and I wish someone had told me this sooner in my life, potassium and hydrogen ions are best friends and will follow each other absolutely everywhere. And the much more scientific way, there's a much more scientific explanation for that, involving sort of one can swap in for the other at sort of sodium potassium channels and blah 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 blah. But basically, if you just remember, when potassium is high, hydrogen ions, i.e. acidity, is likely to be high as well, and vice versa. You will really help yourself out in most situations. So in acute kidney injury, which is associated with metabolic acidosis, you're likely to get this sort of hyperkalemic picture and more of your potassium ions sticking around. If you want the scientific explanation of that, I think there is on the slides at the bottom, but I can't be bothered to read it out. Cool. Another question based on very similar principles. Any takers for this one? Oh, we got some E's coming through. Fab. Yeah, quite right. It is E. It's metabolic alkalosis. This is a really difficult question for JEP1. Don't worry if you can't do this. But this is, again, based on the things I've said already. This makes sense because you've got a tumor that's secreting loads and loads of aldosterone. We know that aldosterone makes you hold on to salt, and in exchange for holding on to all that salt, it drops away your potassium, so it excretes loads of potassium instead in the kidneys, and so you're getting rid of loads of potassium, and so metabolically your body is able to sort of just like I just said, your potassium and your hydrogen are best friends, and so when your potassium goes down, your hydrogen ions are likely to go down as well. So your acidity is likely to go down, and your pH therefore goes up, and so you've got a metabolic alkalosis. What's going on here? Which of the following commonly used medications is associated with an increase in serum potassium? Honestly, the kidneys are all about potassium. Okay, so we've got some B's coming through, a C, which makes me worry that I've worded the question slightly wrong. Hopefully not. Okay, so the answer to this question is D, ramipril, an ACE inhibitor. This is because of the renin-angiotensin aldosterone system, which I'll come back to in just a second. But basically you can rule out a lot of other things. Atorvastatin doesn't have anything to do with this stuff. Furosemide is a diuretic. Most diuretics in general are associated with low levels of most electrolytes, so they're more associated with hypokalemia. And then that also goes for indapamide as well. It's more likely to give you a hypokalemic picture. Salbutamol also is associated with hypokalemia because it forces potassium into your cells. So renin-angiotensin aldosterone system, I'm not going to go through this again because I went through this last time and I used this exact same diagram, which I drew, so I apologize if it's terrible. But basically the bit I want you to focus on is this bit here. So the renin-angiotensin aldosterone system, one of the parts of that is obviously aldosterone, and when you've got loads of aldosterone, like it says here, it increases your sodium reabsorption, and it also decreases your potassium reabsorption, so you get rid of your potassium. ACE inhibitors block this system. So ACE here is the enzyme that helps all this fun stuff happen. ACE inhibitors block off everything below this level, so they block off the effects of aldosterone. They stop aldosterone from doing its job as well. Therefore, you get rid of more salt and you hold on to more potassium, and that's why ACE inhibitors cause a rise in potassium. So useful to know. That question comes up all the time. What about this one though? What is the most likely pathological process here? Hopefully, with something I've already said, you might be able to slide on for a win in this one. Okay, lots of E's in the chat. And the E's have it. It is necrosis of tubular epithelial cells, which is exactly the same as acute tubular necrosis. Tried to throw you off a little bit there. Obviously didn't work. So yeah, muddy brown casts, epithelial cell casts, acute tubular necrosis, hands down. Coca-Cola coloured urine as well is a nice indicator for this. Not in real life, just in exam questions. My urine is often Coca-Cola coloured, and that's often just because I don't drink enough water. Okay, so what is the most likely cause of Eric's acute kidney injury? Could it be my absolute favourite condition of all time, eosinophilic granulomatous with polyangiitis? It could be. I'm just putting it out there. It's not though. You've all done very well. It is in fact B, benign prostatic hyperplasia. We don't know that for sure from this question, but this is what medical school questions love to do. They love to say what's the most likely cause. Which of these things fits with this syndrome, with this presentation? And the reason why is because, like I said before, he's had difficulty urinating for several months. On examination, he's got a tender mass in his suprapubic area. Suprapubic area is basically your bladder, as far as JEP-1 goes. So that is what is there. If there's a tender mass there and someone hasn't urinated in a while, maybe they've got a backup of urine and it's sitting in their bladder and it's making them quite uncomfortable. I once did a bladder scan on a patient who had 3 litres of urine in his bladder. He was writhing in agony. It's really, really painful to have more than 500 millilitres of water in your bladder. It's horrible. So yeah. That is why none of these other answers fit, because none of these other answers are post-renal causes of an acute kidney injury. So in this case, benign prostatic hyperplasia has it. Okay, I think this is the last question. So have a go at this one. And if you're struggling, just remember all the basic principles that I told you at the start. So someone with a pretty nasty AKI, being supported with fluids, his electrolytes are stabilized, but he's still acidotic 2 days later. this is actually quite mean because I think a lot of these answers are valid, and you could probably have a big argument with me about them, but that's tough because I sent the question, and I'm pretty sure that I've seen this exact question somewhere else. So blame that place, not me. So got a few answers rolling in. Someone has said A, sodium bicarbonate. That does help solve acidosis in some situations. However, in this case, he's been acidotic for several days, unchanging. So at this point, sodium bicarb is unlikely to help. So it's probably a bit mean of me including that because it might have been tried at some point, but 2 days later, unlikely to be what's happening. Someone said B, continue with IV fluids. You would continue with IV fluids, that is true, but the most appropriate thing to do next, they love wording questions like this, would be E, hemodialysis. And the reason for this, it just goes back to what I was saying at the start. What are the indications for hemodialysis? They are problems that are not going away despite the supportive treatment you're giving. So he's been having all this supportive treatment for the last 2 days, and this acidosis problem is not going away. So acidosis that isn't going away, dialysis. Electrolyte disturbance like hyperkalemia that isn't going away no matter what you do, dialysis. Intoxication, so this is poisoning or an overdose on something like lithium or other drugs. Dialysis will help sort of clean that drug out of the system. If you're fluid overloaded from a kidney problem and that's not going away, dialysis. If you're really high urea and that's causing you problems, like if you're having symptoms from it, dialysis. That's what you need. And the reason why that is the case is because what are those 4 basic functions of the kidney? Regulate water balance, so fluid overload. Regulate electrolyte balance, so hyperkalemia. Regulate waste excretion, uremia. Regulating acid-base balance, acidosis. So if the kidney cannot do its 4 basic functions, you need to take over the kidney's job. You need to do dialysis. And the only reason why peritoneal dialysis isn't the right answer is because this chap is really unwell. Peritoneal dialysis is something that people can do at home in sort of their own time. The hospital treatment is hemodialysis, and that's what he will be getting. I hope that makes sense. So that, I believe, is the end of my questions, and so I've got a crap meme here for you to enjoy. Just going back the last few slides here, again, this is the kidney slide. This is just like the big high yield slide that I went back to a lot, and also those basic functions again. If anyone has any questions, please do ask them now, or please email me on my email address, which is at the start of the slides. Really happy to answer any questions on this. The kidneys are really tough to get your head around. I'm not expecting, if you're struggling with them a lot now and you've struggled with that presentation, don't panic. It's absolutely fine. You've got lots of time for this stuff to sink in a bit better. I didn't get the hang of them my first year, and it took me until second year and probably seeing a lot of stuff in practice in third year for it to make sense. But if you can put the time in now to help them make a bit more sense, you'll be helping yourself big time in the long run, because the kidneys come up everywhere. They're just affected by everything. Cool, that's me. I will see you next time.
Thank you. Cool. Hey guys, I'm Atch and I'm an F1 doctor in Ealing. So I'll be covering the thyroid disorders today, and put my email there in case anyone's got any questions. So I'm just gonna go on. So we're starting off with an SBA here. So we've got a patient who's had a recent left thyroid lobectomy. They're now complaining of a new onset hoarseness in their voice. Which nerve is likely to have been damaged to cause these symptoms? So I'm going to have a look at the chat. Oh, got a lot of C's here, which is correct. So yes, it's the recurrent laryngeal nerve, and that's something that will always stick in your head. So I've just kind of put this picture as quite a good illustration. So you can see the recurrent laryngeal going right underneath the thyroid gland. So when you're removing this, it's really easy to damage this. The other nerves that I've kind of listed are quite away from it, so they're very unlikely to be damaged. Okay, so just going over some of the functions and risk factors for thyroid. So the function of the thyroid is just to kind of produce and store the thyroid hormones, so your T3 and T4. And T3 is your active form, but T4 is the most abundant, so it's usually kept as its inactive form. Usually regulates your basal metabolic rate. And risk factors for thyroid disease kind of include being over 50 years, having a family history is a big risk factor, any sort of radiation exposure, medications can also exacerbate it, smoking, low iodine intake, and females are more prone to getting it than males. Just kind of the structure, you got your two lobes here and the isthmus, which is joining both lobes, and it just kind of sits over your trachea here. And then the thyroid gland itself has these little lobules here. So it's basically little kind of spherical forms covered in these cuboidal cells, which are your follicular cells, and it has this kind of colloidal filling inside where a lot of things happen, and it's known as the thyroid follicle. So, got another question here. So which enzyme is involved in iodination of the thyroid globulin to produce thyroxine and triiodothyronine? So got a lot of C's here. And yes, it's C. I think I might have just put C as most of the answers apparently. So it is the thyroid peroxidase enzyme. So just to go over the basic physiology. So you get your iodine from your diet mainly, and it comes in the form of iodide ions. And these are taken up into these follicular cells by these sodium iodide transporters. They come into the cell and then they're moved out through this thing called pendrin here, so this transporter here. And then the thyroid peroxidase is really key in oxidating this iodide into an iodine. And this is the form that then goes on to iodinate these tyrosine molecules, which are kind of bundled up on the thyroid globulin here. And these automatically then kind of fuse together to form your T3 and your T4. And these are then endocytosed, and then these enzymes in there break these apart to form your actual hormones. Cool. So just some basic physiology here. So the thyroid hormone increases your basal metabolic rate of the cells, increases your cardiac output, stimulates bone reabsorption, and activates the sympathetic nervous system. And it works in this kind of negative feedback loop. So your hypothalamus releases your thyroid releasing hormone, which then stimulates the anterior pituitary to release your thyroid stimulating hormone, which then stimulates your thyroid gland to release the thyroid hormones. And these then go and act on your target tissues here, so the heart, liver, bone, and your nervous system. Then this also feeds back to the brain, to the hypothalamus and the pituitary. And if there's enough in the bloodstream, then it will suppress the production of your TSH and your TRH as well. So you don't produce too much thyroid hormone. So you've got two different types of thyroid diseases. You've got your hyperthyroidism and your hypothyroidism. The hyper meaning you've got too much, and hypo meaning you don't have enough. And then this is divided into your primary, secondary, or tertiary, depending on which level is affected. So the way I remember it is your primary ones are always your kind of the main gland which produces the hormone. So in this case, it's your thyroid. Then secondary is one level up, so your pituitary, and then tertiary is always where it all begins, so your hypothalamus in this case. So I've got a nice little table here to get you guys to guess what conditions these are. So we'll start from the top. So you have a low TSH, an elevated T4 and T3. So what do you think is going on here? Got a couple primary hypothyroids here, which is correct. Well done, guys. So next one, you got an elevated everything. Yep, it is your secondary hyperthyroidism. Well done. You're on a roll, guys. So next one, it's an elevated TSH, but a low T4 and T3. Yep, so you got a primary hypo. Yep, well done. And the next one, everything's low. Oh, Hashimoto, well, yep, that's also a primary one. So the next one was, yep, secondary hypo. Well done. And then you've got a low TSH in the next one, and then a normal or slightly raised T4. T3 doesn't really matter here. Can be subclinical. So this yeah, so it is the euthyroid, so it's sick euthyroid. And then the next one is your low TSH and your normal T4, which is your subclinical thyrotoxicosis. So these ones are usually due to some sort of illness. The subclinical thyrotoxicosis is more linked to your Graves, whereas your sick euthyroid, it can be linked to anything. So it could be medication, it could also be things like a recent illness like the flu or something like that. And then we've got your last one here. So you've got a mildly elevated TSH, but everything else is normal. So the subclinical thyrotoxicosis is a little bit of a clue here. I don't know if my chat's just stopped updating. Oh, no, it hasn't. Yep, subclinical hypo. Well done, guys. You got all of those. So, does anyone have any questions to go about this? Give it a couple seconds before I carry on. Okay, I'm going to take that as a no. Right, so clinical features. So with your hypothyroidism, so you don't have enough to help kind of boost your metabolic rate. You kind of start feeling a bit tired. You can't keep yourself warm, so you've got intolerance towards cold. You start losing your hair, got a bit of dry skin. Start feeling low, so a bit depressed. Your heart rate kind of slows down a little bit, so you get a bit bradycardic. And then it can also kind of lead to like weight gain in women, menorrhagia, and sort of memory impairments as well. Then you've got your hyperthyroidism, where you've got too much thyroid hormone, so it kind of really boosts your metabolic rate and everything's kind of a bit more hyperactive. So you're a bit more tachycardic, might end up with palpitations, even flip into AF if you're a bit more elderly. You'll be a lot more hyperactive. You'll have weight loss because you're burning off all this energy, and also have an increased appetite. So what goes in just ends up getting burned off. You'll have heat intolerance because you're generating a lot of heat, so you'll be sweating as well. You'll end up with diarrhea. And like because you're quite hyperactive, you'll have this sort of hyperreflexia, have like fine tremors as well. And if you feel around the neck, you can also sometimes feel the goiter, so that's your enlarged thyroid gland. And then some signs that you kind of typically see when you're doing an examination would be the palmar erythema, the oncholysis of the nails, and then we'll usually test like for muscle weakness and wasting as well. And then again, in women, you'll get oligomenorrhea or amenorrhea. And then this is kind of a branch of your hypothyroidism, so your Graves' disease. So these are more worrying signs. So your exophthalmos or your proptosis, your chemosis, so these like your eye signs, having a diffuse symmetrical goiter. So just imagine this massive mass kind of in your neck. So that's going to kind of affect various different things. So your voice from breathing as well. Pretibial mixed edema, which is quite rare, but if you've got a severe disease, you will get that sign. And any other kind of autoimmune conditions are linked to Graves. And you can also hear the thyroid rates as well. So typical investigations are your TSH and your T4, which are looked at, and it usually takes about 8 weeks to adjust. So you'd want to wait till about 6 to 8 weeks before you recheck the bloods if you started them on any kind of medications. So your free T3 isn't usually tested in a normal blood test. You would have to do that separately if there's an indication for T3 toxicosis. So it's usually used to identify any early toxicosis. And then you'd check a couple antibodies to identify either Graves or Hashimoto's. So TSH receptor antibodies for Graves and antithyroid peroxidase for your Hashimoto's. So if you kind of go back, if for Graves' disease, if you've got TSH receptor antibodies, you kind of start losing that feedback. Whereas with the antithyroid peroxidase, if you don't have that, you're not producing enough of your thyroid hormone. And then you can also do your ultrasounds to kind of identify what kind of mass you have in your neck. So if it's cystic or solid, and trying to differentiate to figure out if it might be malignant nodules. And you might want to do a fine needle aspirate as well if you're going down that kind of malignancy cancer path. You can also do isotope scans as well. So here you're given radioactive iodine, and then you scan the thyroid gland to see the uptake of it. And this is quite useful to kind of detect your hyperthyroidism and see if there's any kind of ectopic thyroid tissues growing around or any kind of thyroid mets anywhere. Okay, so you got another SBA here. So a 35-year-old lady visits the GP to review her recent blood tests. She initially presents with a 6-month history of feeling unusually tired and had a low mood. She also noticed weight gain, but claimed there is no change in her diet. What are the results below suggestive of? So give you a couple seconds. So, so we have a diagnosis that isn't thyroid. So E, yeah. So I'm glad no one fell into any traps here and felt they had to be pressured into picking something else. So yeah, it is a normal thyroid test. So I put euthyroid in here as an option just to kind of trick you guys. So something will be slightly abnormal, even though the rest of it is normal for euthyroid. Whereas hypo, and hypo are quite obvious, the test. The TSH and the T4 will kind of go opposite ways. Oh, next one. So you got a 45-year-old lady who has a history of feeling increasingly anxious for the past few months, and her vision is worsening. She feels she gets too hot and sweaty even when it's cold, has noticed significant weight loss, and she's been eating more than ever. And also reports she's noticed her periods have been getting lighter and less frequent. She also said she feels like there is a lump in her throat. What does her TFTs show? So we've got a few Ds here, which is correct. So it is secondary hypothyroidism. So everything's elevated. That means your brain's basically telling your thyroid gland to carry on producing it, and there's no negative feedback going there, or it's ignoring it really. So we're getting to the end. So just to go through some causes and some management. So for hypothyroidism, so Hashimoto's is your autoimmune version of hypothyroidism. You can also have any kind of surgical interventions or radioiodine treatment, which can cause hypo as well. So removing the thyroid gland, for example, would lead to that. Iatrogenic, so just no known cause. Having TSH deficiency, having iodine deficiency, so but that has to be quite severe, and any sort of congenital defects. And the basic management for it is just giving them levothyroxine, and that's usually taken in the mornings, and they have to make sure they take it on an empty stomach and don't eat anything for about half an hour. Then hyperthyroidism, so you've got your Graves' disease, which is your autoimmune version of it. You can have toxic multinodular goiters, thyroid adenomas, thyroiditis, high intake of iodines or any drugs, excessive intake of any thyroxine, and your management is using any sort of anti-thyroid drugs, so your carbimazole. And if it's in a young female of childbearing age, you'd want to check if they're pregnant or are thinking about getting pregnant, so you can give them propylthiouracil instead. You'd also put them on that if they're not really tolerating your carbimazole as well. And then radioiodine treatment, or ultimately thyroidectomies, with or without giving them levothyroxine. So if you have a kind of, if you just remove one lobe, you can kind of live without your thyroxine being given to the patient. That's it from me. So please do fill in the feedback form. And if anyone's got any questions, that would be great. If not, thanks for sticking around, guys.